our goggles in real time osteotomies that then go off to be translated into cutting guides and a prosthesis. We're already utilizing that now, but I think the next big advance in the surgical arena is going to have the surgeon with goggles with a heads-up view where they can have an overlay of what they're looking at, both vascular anatomy and a radiographic picture to understand what may be in that vicinity that they are clinically working on. I think that'll be a great advance. When it comes to materials, I think it's going to allow us, and we're playing around with this, how to have a more perfect, closer to a definitive prosthesis earlier on by perhaps having the design 90% done, do the operation, re-scan the operative field, and then finish the prosthesis and deliver it with minimal turnaround time. So
thank you so much.
We see.
With that, I'm sorry we could not answer all the questions because our time is up. Thank you so much again, Larry, for the great presentation. Thank you to the audience from myself and from Bone Marrow Integration Centers. If there are any other questions you have, you might send us an email and we will be sure to answer that. With that, thanks everyone. Thanks there again, and hope to see you at another Bone Marrow Integration webinar in the future. Thank you so much.
Thank you to Dr. Brecht for sharing his vision, clinical experience, and the role of digital technology in reconstructive care. The Implant Symposium 2025 continues shortly with our next presentation. Our third session, Improving Your Scanning and Bite Registration Strategies in All-on-X Cases, delves into the nuts and bolts of full-arch digital workflows. Professor Amma El-Kadem will review scan aids and walk us through a radial scanning protocol, offering pragmatic tips for bite registration in edentulous implant cases.
Good afternoon, everyone. My name is Amma El-Kadem. I'm a professor of prosthodontics, Cairo University. I'm also the director of the Artificial Intelligence and Digital Center in our dental school. I'm also a fellow and diplomate of the ICOI, and I'm running an educational academy for implant training called the Cairo Implant Academy. I'm living here in Cairo, Egypt. I'm really delighted to have you all in this webinar talking about the improvement of scanning and bite experience when doing full arch cases. So I'll just start with the presentation now. And actually, what we're gonna go through today is how to make your digital life easier when doing full arch cases. A lot of people are having problem with using the intraoral scanner for the big full arch cases. So I'll be talking about how to improve the scanning experience and get more accurate and more predictable results for scanning full arches. I'm also going to tackle a really very critical subject about recording the jaw relationship digitally using different techniques. So let's start with the scanning first. Everyone knows that doing a scan for a single crown or an inlay or a veneer whatsoever is really very easy, and anyone now with the current technology can do this. The challenge that everyone is facing is that when he's doing a very big case, a full arch case, we're having problem with the accuracy of the full arch cases. And so my first part of the talk will be focusing on how to improve this. And really, if you go back to the physical world, when we used to do impressions, the open tray impressions and the splinting and the verification jigs, everyone knows that because we're using a lot of materials that have some sort of dimensional changes, the accuracy of the final product was always not good. And we had a lot of problem regarding the seating and the passivity of our restorations. And I used like 15 years ago, I used to cut a lot of metal and resolder and do a lot of work. And this is not your problem. This is everyone's problem in the world, because the physical workflow has a lot of materials, a lot of flows in the techniques, and all those flows and dimensional inaccuracies would result definitely in an error. And we had that very simple thought that if I'm having an expansion of the investment like 2% and the shrinkage of the metal 2%, so they will negate each other and we have a good restoration. And it doesn't work like this. And we know for sure that for the physical workflow, it's impossible to achieve a 100% passive fit. And we used to accept a certain level of misfit that we call the accepted misfit, which is like around 100 or 150 microns. And really, this was acceptable with the precious metal frameworks, but with some materials like zirconium, probably this is not acceptable. And we had the thought when we started using digital technology and with the improvement, especially with the intraoral scanner, that we can replace the whole workflow from physical to digital. And this means that we are going to replace the image acquisition from the physical impression to the digital image acquisition using the scanners, doing digital designs instead of wax patterns, and doing CAM manufacturing instead of casting and similar stuff. And with using this digital workflow, we aim to reduce the impact of dimensional changes of material, the impact of individual variations between different operators and technicians to get more predictable results. And if you have been there with the prosthetics for a long time, you know that the labs are very good with the design and the milling. They are more advanced than clinicians. And we were the weak link. Doing the scanning for a full arch was the weak link in the whole solution. So my talk today would be about improving the scanning for the full arches so that we are not the weak link anymore. And in order to understand how to improve the scan, you need to understand the problem first. And the problem is technically that you are using a scanner, a device that have like a small window, which is like 1 centimeter by 1 centimeter or something like that. And you are taking small shots, which we call frames. You're taking like maybe 1,000, 2,000 frame. And the job of the software you're using with the scanner is to stitch those frames together. And the way the stitching is done depends on the presence of common features. For example, this is just a hypothetical image. If this is a frame and this is a frame, so this is common, so he can stitch them together. But when you have something like this, mucosa, non-keratinized mucosa, which is movable with saliva, which we face a lot with the lower arches, the stitching is actually very problematic. And you cannot join the images together in the best possible way. And this is when we start to have problems. And also, when we are scanning a big case, like a big full arch, we are taking a lot of frames. So when you have a lot of frames, the possibility of stitching errors becomes more, and consequently, the overall result of your scanning is not very good. And this is really a big problem. You're not going to face this when scanning teeth, because teeth are very characteristic. The stitching is very easy, but you're going to face this with edentulous patients when you're doing dentures, or when you scan a full arch implant case and you have a very bad soft tissue topography. So what's the solution for this problem? The solution is really very easy. And it has been there in the literature for a long time, and it's called splinting. The guys who have been using physical workflow used to splint impression copings to make them rigid together so that the dimensional changes are not very significant. But the aim of splinting here is much different. The aim of splinting in this scenario is just to create an optical track. When you move from this scan body to this scan body, and just go to the pointer, when you start moving from this scan body to this scan body, you're having like an optical track. This optical track is carrying you from one scan body to the other, making the stitching process more predictable. Have been there in the literature for many years, and actually you can find different names for this. They call it splinting, or you might find the word continuous scanning strategy, which means that I'm creating an optical track for my scanner so that I have a reliable way to stitch the images together. I'm sorry for this. So How to do this? There are many ways. The simplest way is using like any gadget in the clinic. I can use like those are the bond brushes for the composite. We used to cut them in small pieces, hold them, and glue them with flowable composite to the skin bodies, taking into consideration not to cover the top of the skin body, not to cover the characteristic feature of the skin body, and just to keep a little bit of space between this stick and the soft tissue so that we can scan the soft tissue beneath it. So this is a very simple way to do it. Also, there are a lot of gadgets. You can find them. This is actually one of my designs for this. You can just scan this QR code and you can have print them, and you can just join the scan bodies with this very simple gadget, and you scan your patient, and it really works very nicely. This is one other forms. You can also scan this QR code and you can download and print it for free. This is like a honeycomb mesh with different sizes. You start by scanning the soft tissue, and then you join the scan bodies with this rigid structure. And eventually, when you have this scan, you can also remove the scan bodies with this splinting jig, and you scan it outside the patient mouth so that you have a more reliable scan. And then you can consequently join both scans together, and this gives you a more reliable scan for your cases. But really, the concept is the same. It's the same concept. You can just use any splinting aid to join things together. I have a lot of colleagues who are using very nice things like the Q-tips, the ear tips, and the elastics, the power chains, and everything, and consequently they all work, and you can get very good results if you splint your scan bodies. So we had a question. I'm a research person also. I'm doing a lot of research in our dental schools. We have a lot of very active candidates working. So we had, like a couple of years ago, we had this question. Is really the splinting effective, or it's just a fiasco, just a publicity show? So we were having like two groups of models. The first one, we scanned the scan bodies without splinting. The second one, we used one of those gadgets to splint. And then we produce a verification jig of metal. And this verification jig of metal for the same model with the two different scans, we just put it on the model and we start measuring the gaps at the interface. Like this one. This is one of the milled verification metal jigs. And this is the multi-unit interface. And we start measuring the gaps and the interface. And our results shows very clearly, very significantly, that splinting the scan bodies, whatever the type of the splint, would result in a significant decrease in the gaps at the interface. So if you look here, the average gap at one of the implant sites was like 25 microns without splinting. With the splinting, we're probably below 20, which means that we have reduction in the gaps of when using a splint, like 25 to 30%. And this is really good. This is a really good improvement. Really, what's more impressive than the reduction in the gap is the scanning time, because we used to measure the scanning time for both techniques. And we noted that using the splints makes the scanning much faster. And this consequently makes the number of frames lesser, and probably this is one of the causes why splinting provides better accuracy in addition of reducing the scanning time. So my recommendation here, if you want to have a better scan, you splint your scan bodies. And probably all the implant companies and the third-party companies, they understood this logic, and they said, okay, we're gonna provide our doctors with some modification in the scan body design that allow them to do this type of optical splint. So now you're going to see in the market a lot of companies providing you, whether they are implant manufacturers, whether they are third party, whether they are scanner companies, they are going to provide you with different types of scan bodies that would help you to optically splint the cases together. So I have tried a lot of those, probably 90% of the gadgets in the market for this. I had the privilege of using them and trying them. And actually, from a scientific point of view and a critical point of view, they are not the same, because the way they are aligned on the arch and the way we scan them is not similar. So we can categorize them or classify them into three types. What we call peripheral or parameter splinting aids, and what we can call the radial splinting aids, and what we can call the central scanning aids. Okay, so let's see the difference between them, so that as a user, for you as a clinician or a user, when some company brings you one of those, you need to understand the logic and know if this is the perfect scenario for you or not. The first type is what we call the parameter or the peripheral splint. And in this technique, what we do is that the scan bodies that the company provides, they have like a sort of a horizontal arm, and you align them with the parameter of the arch, as you can see right here. And then you get your scanner tip and you start scanning from one side, and those arms are carrying you from this side to this side, providing you with an optical splint that makes your scanning an easier experience. So this is called parameter or peripheral splinting. And technically, this is one of the systems. This is a very nice system. When they have their regular scanning body, they are adding like a screw attached arms. And you can find this a lot in the market with different implant systems. And when you place the arms, you place them in a way that they bring the scan bodies closer to each other. They might have different shapes and forms, maybe one with the T arms, one with the two horizontal arms, one with single arms. They have to be a little bit different so that the overall shape is not mixed together. So at the end of the day, the aim of those horizontal arms is to bring the scanning experience in a splinted manner, creating an optical track for our splint. A lot of systems are using this. The second way is called the radial scanning. And in the radial scanning, the companies are providing you with scan bodies with a horizontal projection like this that have a very characteristic shape. And they recommend to you that you align those scan bodies so that they meet at the center of the arch, which means that the center of the palate or maybe at the floor, over the floor of the mouth in the lower arch. And what you need to do here is that you start from the center of the arch, because when you start scanning the center, probably the first frame is getting an image for all the scan bodies together. And this is what we call the reference or the zero frame. And from this zero frame, I will start moving to the periphery to get the whole scan body, and then go back to the center, to the reference frame, and then the second one, and then go back, then the third one, and go back, and so forth. You're going to do this with every scan body, and every time you go to the periphery, you go back to the center, to the central frame. And this guarantee that I'm having a specific reference that guarantee the accuracy or improve the accuracy of my scan. This is the logic for the radial scanning. And this is one of the systems for the radial scanning. This is very nice because the system here allows not only scanning from the center, it allows also for automatic registration of the scan body. And once you scan the scan bodies, the filter of the software opens, and then you can remove the scan bodies and go back and scan the soft tissue. This is the reverse. I'm not scanning the soft tissue first. I'm scanning the scan bodies first, because this eliminates the factor of artifacts from the soft tissue movement. The same here in the upper arch, a central start. Then you go to one scan body, then the second, third. Here we have 5 scan bodies. Once they are all registered, the filter of the soft tissue opens, and I record just a small bit of the soft tissue. Then automatically he removes the scan body or hide them, and I can go complete the scan for the soft tissue. This is really a very nice idea to improve the quality of the scan for the scan bodies, eliminate the effect of soft tissue movement, and consequently get a better scan. The nice thing here about this workflow is that the software will automatically replace the scan body which he used with any of the generic scan body. Here I'm using a specific scan body for an implant company. So I just selected from the library, and it automatically places the conventional scan body at the exact location. And this will help us a lot with the stitching problems the CAD software like ExoCAD or FreeShape can face during matching my scan with the numerical scan body, because at this instance, the resultant file that goes to the lab is actually a numerical scan body, which is really a very nice idea to do. The lab can go from this point because he is having the numerical scan body. He can align the connection, do the design, and consequently, we can end up with a very nice and accurate design for those cases. The third strategy is what we can call the central scanning. And this is a little bit different. Really, probably can almost one company is doing this. But it's a different idea. We need to understand why they are doing this. They say that the problem is that you are taking too much frames. You're scanning a lot of frames. So we are going to reduce the number of frames, and we are going only to scan the center, which is those scan bodies align at the center, like the radial technique. But actually, I'm going to scan only this characteristic part. I'm not going outside like the radial scanning. I'm going to scan only the central part, which means that I'm going to scan a small area. And this means that the number of frames is reduced, and consequently, the stitching problem is much reduced. So I'm going to scan only the center. But because I'm going to scan only the center, I'm having a very big problem, because the relationship between those scan body and the soft tissue is not registered in this manner. So what they really do is that they give you a kit with the scan bodies and also with specific healing colors. Those are the healing colors from the company itself. So you will start by scanning the arch and then scan the healing color, and then you are going to put this part and scan the center. So eventually, I'm having two scans. The first one is a scan body for the soft tissue with the healing colors. And the second one is just a scan for the central part only, which they call the central zone or the true zone. And they have an intermediary software, which is a software free online. You have to get your scan outside of your scanner and go to the intermediary software. And the software would automatically place numerical healing colors in the exact location of the implant based on the shape of the central part. And now we have healing colors generated by the software in the correct position. And all what we need to do is that we get those healing colors and align them with the initial scan to get the relationship between the healing color and the soft tissue. If you have a very quick look here, this was the first part we scanned, second part, third part, and you see this is the fourth one. And you see this, there is a discrepancy between the position of the actual healing color and the one scanned with the arch scan. And this means that the initial scan was not accurate, and we know because of the stitching problem. So we will take the shape of the soft tissue from the yellow scan, and we're going to take the exact implant position from the central scan. So this is how it works. We scan the healing colors, and then eventually we put the scan bodies and we just scan the center. A very small scan. It takes like 4 or 5 seconds. And we go to the intermediary software and just one click at the center, and the software automatically will recognize the scan bodies and will generate the healing colors at the exact location you're looking for. So there's an extra step here. We need an additional software. It's free, but we need to go there, do the alignment, and then bring this back to the initial scan, and the lab can join them together. It's very nice, easy technique to scan, but really requires a little bit of work from the lab to align the scans together. The question here, okay, I can scan without a splint, I can scan with a peripheral, a radial, or a central splint. Does it really matter? Do we have a difference in the accuracy? We are conducting a very big study about this with different systems and different protocols. And what we do is that we're doing this study on 2 parts, part on a model and part with patients. And we scan the model with different techniques, having a reference, which is a coordinate measuring machine, and we start to measure the differences between the different techniques. And let me give you a small brief about the results. After we scan the same model or subject, we get out the produced multi-unit position, we align them together with a special software, which is a Blender software, and then we start to measure the differences in the X, Y, and Z. And to go a little bit with this, we have to understand some items. The first thing is that if you're asking about the impact of the type of the splint, actually, the impact lies in the horizontal direction, which is the mediolateral and the anteroposterior. With the vertical position of the scan body, the differences between the systems is not significant. So we don't have a problem with the position of the multi-unit up and down. We have a problem with the position of the multi-units mediolaterally, which is the distance between the right and the left side, and with the anteroposterior, and consequently with the resultant position. And let me give you like a brief summary about this. Our results are saying that the non-splinted one, which is the purple one, this has the greatest deviation errors, which is probably like 25 microns in the resultant. And if you use different types of peripheral splints, like the green and the light blue one, the accuracy is improved. It's like 20 to 25% improvement. But when you go central and radial, the two techniques, when we place the scan body to the center, whether we scan from the center outside and back, this is called the radial, or we just scan the center, the accuracy is really improved. Okay, the central and the radial scanning is really great. It improves the accuracy a lot. Probably like 60 to 70% of the errors are reduced. And this is significantly very high. So if you ask me which type of splint to use, I would go to the radial splints or the central splints, because technically the results of the accuracy, especially in the horizontal deviations, is really much better. And this is something we have to consider when we're doing especially lower full arch cases. So my conclusion here is that, please, if you're having a full arch case, especially if it's a lower case, with upper cases, the palate is very characteristic, the scanning is much easier. But if you have a lower case and you're having larger inter-implant distances and the soft tissue is not very well defined and keratinized, your solution is splinting. Okay, so you splint. Which type of splint? If you have the choice, I would go to the radial and the central splinting aids. They provide better accuracy and more predictable results. Now I'm going to my second part of the lecture, which is about registering the jaw relationship. And really, this is a very interesting subject, because a lot of the guys who want to do implant prosthetics, they hate complete dentures. You don't like dentures. Oh, I don't do dentures. And let me tell you something. Doing a full arch case is exactly like doing a denture, but without a flange. So you have to understand all the concepts of complete denture regarding the centric relation, the maximum intercuspal position, the vertical dimension. If you don't know how to register them for complete denture, you have to revise your strategies, because you cannot do a decent full arch restoration if you don't know the basics of complete denture. But I will try here to tell you the way of doing this in the digital era. So just bear me a little bit. I'm going to start a little bit, because I know my audience is a mixed one. Some of the guys here are general practitioners, not a professional prosthodontist. So I'll go a little bit with some of the old concepts just to refresh the minds about them. The first concept is the centric relation, which actually the centric relation is a definition, refers to the position of the condyle. You can call it the zero position, or the position where the condyles are in the relaxed position, where the patient feels fine, where the patient can start chewing and grind hard food in this position. Really, the definition of the centric relation have changed a lot through the years. And really, there are two schools. The old school, which was really related to the mid part of the last century, they used to say that the centric position is the relation between the maxilla and the mandible when this condyle is in the most retruded, unstrained position. So the condyle is back. Okay, the definition was changed a little bit in the 70s, where they used to call it the round position, or the rearmost, which is the most posterior, midmost, which means the mediolateral, and the uppermost. So the rearmost, uppermost, and midmost position. This means that the condyle is actually they consider it in the centric when the condyle goes back. And just remind this for a moment. Actually, in the mid-80s, this was totally changed, because after doing a lot of CTs for the condyle, the prosthodontists start to think that the centric is not the most retruded, it's not back here. They start to say that the centric position is the position of the relation between the maxilla and the mandible when the condyle articulates with the thinnest avascular portion of the disc. So there is a disc here. I'm just contacting with the thin part of the disc, the central part of the disc, and that the condyle and the disc complex are situated in the anterosuperior position. So the condyle is not here, the condyle is here. Okay, so this is really a debate. So is the condyle back, or the condyle in the anterosuperior, if you ask anyone now to tell you, he would tell you it's the anterosuperior position. But really, if you ask me as a prosthodontist, we have been doing dentures with the retro position. It's fine. We're doing dentures and restorations with the anterosuperior. It's fine. Because really, the condyle, the centric, is not actually a definite point. It's more or less a small area, which we call the long centric. And really, I'm just telling you the most recruited and the anterosuperior because it only matters with the way you are recording the centric. We're going to see this in a moment. Because all what you care about as a dentist is that how you can guide the patient to the centric position. So actually, to guide the patient to the centric position, we have two types of techniques. One of them is called the passive techniques, and the other one is called the active techniques. So with the passive techniques, the patient is doing nothing. He's doing nothing. Me as an operator, I'm just doing the whole job. I'm just telling the patient, we need to do this and this. I'm guiding the mandible manually to the position. For the active techniques, I'm asking the patient to do some effort to guide him or to aid me to the centric position. Let's see how we can do this and technically if there is a difference between the techniques. The first one with the passive techniques called the chin push guidance, which means that you're going to hold the chin with like a couple of fingers and the thumb, and you're going to push the chin backwards. The guys who are doing this believe that the condyle should be in the most retruded because this was just suggested in the 60s. So this is actually aiming to produce the most retruded. This is not the best way to do it, really, because when you push the patient back, he usually makes a reflex and pushes you to the front. And this makes the record very bad. And the second thing, if you are a right-handed operator and you just push the patient to the back, actually there is some sort of a lateral component of the force. So you might shift the jaw a little bit to one of the sides, and this is not good. So I don't like this very much, but some people can still use it. The other way to decrease the effect of the pushing back and push a little bit to the top is just to place two fingers below the ramus here, and you push them up and then with the thumb back. So you're just trying to push the condyle a little bit to the back, a little bit up. And this is called ramus-assisted chin push guidance. The most standard way, which was suggested by Downson and his colleagues, which really based on the idea of the anterosuperior, is that we are going to place 4 fingers at the ramus just here, and you just sit in the 12 o'clock position to the patient, and you push the ramus up, and you push the chin down. You are rotating the mandible to push the condyle in the anterosuperior position, and this is called the bimanual guidance. So I would prefer you to use the bimanual guidance, but some people would still use the other ways. Just find the best way you can relax your patient, push him or guide him to this position, and sometimes you need to train him a little bit. Maybe you just consume like 5 or 10 minutes to do so. You can help yourself by asking the patient to swallow or move the tongue back to touch the palate, because the action of the tongue in both scenarios would just carry the mandible a little bit to the back and help you to carry the mandible to the centric position. But you cannot rely on this only because you need a lot of patient cooperation, and sometimes the patient cannot help you. So I would prefer to just combine active with passive. Maybe I use the bimanual with the tongue retrusion, so give me better results. By this way, you are carrying the mandible to the centric position, but you have to understand something, that the centric is actually a 2D. I'm just pulling the mandible a little bit to the back and not to the right or to the left. So it's a mediolateral and anteroposterior relation that is missing a very important thing, which is the vertical dimension, which is the distance between the upper and lower jaw. And because we do not have teeth, we do not have occlusal stoppers, and probably this is a major problem. So the second question, how to know the correct vertical dimension? And really, most of the people are depending on their guess, their subjective method. So anyone would look, you tell me, Amr, this patient has a good vertical dimension. This one does not. And probably they depend on the dropping of the corner, the chin-nose approximation, or something like that. Those are called the subjective methods. And really, I'm an expert prosthodontist. I've been doing this for 20 years. Probably I can do this very easily, but it is not reliable every time. And really, the best way, the best way to know the exact vertical dimension is the facial proportions. And you need to understand that our face can be divided into 3 equal thirds. Those 3 thirds are from the hairline to the nasion, from the nasion to the base of the nose, from the base of the nose to the tip of the chin. And actually, the middle part is very stable, does not change. I don't have hair, so my third here, you cannot judge it very accurately. But this middle third is fixed. So if I want to know my exact vertical dimension, I would go measure the distance from here to here with my digital caliper, and then let the patient bite on whatever structure. We're going to see this later on, so that this third is equal to this third. So this is an objective way to determine the vertical dimension of occlusion. You have a play of plus or minus 1 or 2 millimeters up and down, but really, this is very, very objective way, and it would help you. I believe this is a very essential tool. If you are doing good prosthetics, you should have a measuring tool so that you have a reference from the nasion to the base equals from the base to the tip of the chin. Sorry for this. Okay, let's go digital. Now I need to register my jaw relationship in my All-on-X cases. What should I do? I believe we have 3 different workflows. Depending on your case, you're going to choose the one that suits you. The first one is to use the preoperative temporaries. If the patient is having a preoperative temporary, this would be very nice. The second way, if the patient does not have a temporary, I need to create what we call an anterior deprogrammer. And the third way is to go a little bit back and construct an occlusion block. We are going to see how to use the 3 methods in the digital workflow. The first way, this is really the most reliable way. If you are having a patient that you did implants, or maybe he is having like some remaining teeth with a temporary bridge over it, you can scan the temporary bridge first. You scan the upper preoperative arch, the lower preoperative arch, and you scan the bite. And this is the best bite you can get, because actually the patient have been using this temporary for a time. Even if you have discrepancies, you can just adjust them with an articulating paper and you scan it. And eventually you can cut the bridges from the scan, place your scan bodies, and the relationship is maintained. And eventually you will have the same jaw relationship that the patient had with the temporary. And this is really is a very nice way to do it. So if you have the temporary of the patient, if you're doing immediate loading, you have temporary, you scan the upper arch, you scan the opposing, and you scan the bite before removing the temporary and start doing the rest of the workflow. So this is very easy. Whenever you have this, do it. Okay. What if I do not have a temporary bridge? I just place my implants, I come to the second stage, place my multi-units, and I want to do scanning for the bites. Here comes the role of what we call anterior deprogrammers. What's an anterior deprogrammer? The logic of the anterior deprogrammer is really very simple. The centric occluding relation, which is the centric relation plus the vertical dimension, this is called the COR, or the centric occluding relation, is like a table. And the table has 3 legs. We have 2 legs at the condyles here. Those are always there. We are missing the 3rd leg, which is the stabilizer in the front. So if you can create an anterior hard object the patient can bite on, so that he's biting at the correct centric and at the correct vertical, this means that you have stabilized the centric occluding relation and you can scan the bite from this point. So the deprogrammer should be a hard structure supported by a hard structure, and the top of the deprogrammer should be flat, and preferably the inclination of this flat part should be a little bit coinciding with the movement of the condyle. So how to create this deprogrammer? The guys who are doing full mouth rehabilitation with teeth, raising vertical dimensions or correcting problems with the team, they know the deprogrammers. They know a lot about the leaf gauges, about the Lucia jigs and how to use it. But with the edentulous patient, we cannot use leaf gauges or Lucia jigs because we don't have anything to bite on. So we have to think it over how to create a deprogrammer. And really, My easiest way to do it is to use a very nice material called the green stick compound. It's like a type of wax, but it's a type of hard wax. The guys who are doing dentures and doing border tracing know this very much. The green stick is a very nice material. You can buy it from any supplier. You can just soften it in the hot water. It becomes very soft. You can adjust it the shape you want, and then you just spray it with some air or maybe some triple way syringe water and air, and it becomes hard, rigid, very hard. You cannot use pink wax because it does not get hard enough, and you cannot use the silicone, the putty silicone, because it is a little bit springy. So I would like to use this material. So how to use it? You can use it with many different ways. You can use it directly on the multi-unit abutments. You can use it over one of the scan bodies. You can also use other ways to do it. You can use it with the soft tissue. So let's see some examples how we can create this deprogrammer. The first way is to do it on the multi-unit when you have very limited space. Only very small space just for the crowns. So if you just place the scan body and ask the patient to bite, the scan body is raising the vertical damage. So you just remove the scan bodies and you soften piece of this green stick compound. You just soften it, adapt it over one of the multi-units so that now it is supported by a rigid structure, which is the multi-unit. And then you are going to flatten the top with your finger, make it flat, and then you ask the patient to bite. You guide him to the centric using whatever way, bimanual with tongue retrusion would be good. And then you check the vertical. Okay, now I measure the vertical. It's a little bit high. No problem. You just get it out, soften it a little bit, compress it down with your finger. Now it's shorter. You try it again. Maybe it's the vertical dimension is low. You just go soften it, make it higher, flatten it, and cool it. The most important thing that you do not leave it soft and ask the patient to bite. It's not a bite recording material. It's just a deprogrammer, a hard object to bite on. Okay, so for this specific case, as you can see, we scan the upper arch for the patient. He is having a temporary bridge over this, the anterior temporary bridge, waiting for his implants at the back. And we scan the lower arch, the scan bodies. This is also a radial scan. And then what you do is that you ask the patient to bite over this, and you scan the bite while the patient is closing. It really works very nicely. You can scan the bite right and left, or you can scan only one long bite front and then go back over this and one bite. You can do this or this, it works. I would like to have one single bite, not like the teeth with the right and left bites. I would like to do one single anterior bite. Okay. The other way, if you have a big space, like this case, we had an upper and lower scan, and those are my scan bodies here. You can see the scan bodies. So I just do my arch scan with one scan body. And I just put my green stick material over one of them and flatten the top and ask the patient to close until I get a vertical and a centric, and I can scan the bite, as you can see. Sometimes the bite recording is not automatic, so I just go select one point and do like some sort of manual alignment to the bite, and the scan bodies would help very much with this. So the second way of using the deprogrammers is to use them over the scan bodies, and this happens when we have plenty of space. Okay, so this is the use of an anterior deprogrammer over the multi-unit directly or over the scan bodies. We have some gauges. We have been trying this for a while. This is actually a bite aid. We call it the bite aid or the implant anterior deprogrammer. And simply, it's actually a part that fits over the multi-unit with a screw. It's like a scan body or an abutment or just a screwed structure over the multi-unit. And it has like a ball and socket joint. This ball and socket joint allow this part, this triangular part with the arm, to be adjusted based on the occlusal plane. And we have different attachments with different heights to accommodate to different vertical dimensions. So this anterior deprogrammer is really very nice to use. We do not need any other material. We just get this deprogrammer, and let's see how it works. Here I'm scanning the upper arch. For this patient, this is a lower edentulous patient. I just scan the upper set of teeth. And then I'm putting my radial scanning scan bodies for the lower arch. So now I'm just doing the radial scan. I'm scanning the center as we said before. and we're going from the center outwards. And eventually, when I finish, the lock for the soft tissue is open. Now I'm scanning the soft tissue. And then I'm going to remove my scan bodies and continue my soft tissue scan. And when I finish my soft tissue scan, I get this gadget, this very nice tool you see here. It has a locking screw now. It is freely to move. Okay. I'm just attaching it to one of the implants. Then I'm freely adjusting it to be aligned properly with the ridge. And then I'm locking this anterior screw. Then I choose one of the plates, which are made of resin or metal. And I'm trying the centric relation. If I need a higher one, I can get it. I'm asking the patient to move front and back, front and back. This is like the Gothic arch tracing until I'm getting the centric. Then I just let the patient bite and I'm scanning my bite. Really, it is very handy, very easy to use and universal. You probably can use it with almost all scenarios. Okay, so this is the anterior bite deprogrammer, anterior implant supported deprogrammer. It's another way to do it. Okay, if I don't have enough structure, upper and lower, can I do it directly on the soft tissue? Yes, you can use the green stick as an anterior deprogrammer on the soft tissue, but really, this is very tricky. This needs a very experienced operator, and probably you might have some errors. So in this case, I'm having an upper edentulous arch. I'm going to do a denture, and I'm having a lower temporary for the patient. So I scan them before I remove the temporary, and I create the deprogrammer. This is the anterior deprogrammer supported by the soft tissue. And while the patient is biting, I'm scanning part of the soft tissue, and I'm scanning the bridge, and the bite is aligned. Is this accurate? If you're experienced enough, you can get it, but technically you might have some error. So the question here, the deprogramming itself, the process of deprogramming, it's a very difficult process, by the way, especially if the patient is having a habitual bite. So is it always accurate? It's, if you are good enough with this, you can get very good results. But don't worry, even if you have a small error, okay, you get the wrong bite. Let me say it like that. You get the wrong bite. What would happen? I'm going to make a try-in for the patient, an implant retained try-in. So if I go to the patient, I'm doing the try-in, and I don't like the try-in, no problem. All what I need to do is to do the adjustment, the required adjustment in the centric and the vertical in my bridge. This is my try-in. And then I can get a very nice jaw relationship as if I'm having a temporary, like the most reliable way, which is the temporary. And you see now, I'm having, this is my case, I'm having a very good bite using a screw retained temporary bridge. So this is like a corrective bite to correct the improper jaw relationship. So really, you don't have to worry. This is not a big deal. If you have a problem with the initial bite scan, you can always correct it in the try-in. Just send the new bite to your lab, and he will just relate everything in correct position. The third way to do it is to use record blocks. And really, this is very standard, but it requires an extra step because you're going to scan the arch first, whether it's a complete denture like this, or maybe if you have implants, you're going to scan the implants, and eventually you are going to construct an occlusion block. And the occlusion block should have a very small rim because we're going to adjust this with the pink wax or any bite registration material. So you construct a digital record block and you start recording the jaw relation record with this record block. And when you record the jaw relation record, you scan it. You can scan it inside the patient mouth or just bring them outside the patient mouth and scan them. You can help yourself by adding the midline, the smile line on the bite wax so that it helps your technician when setting up the teeth. So you just design occlusion block, print them. You take the bite and you scan the bite with your scanner and the problem is solved. Some people would say my problem with complete denture bites is the movement of the record blocks. So if I make record blocks which are soft tissue supported, I might still have a problem with the bite. And here in this scenario, we are going to improve this by making what we call screw retained occlusion blocks, which means that during constructing the occlusion block on the software, I'm going to make a hole opposite to maybe a couple of the implants in the arch. And we print those occlusion blocks like this. And before making the jaw relationship, we just put like a metal sleeve, a short metal sleeve join it to the occlusion block with some composite material, and now my occlusion block is fixed, a fixed occlusion block. I then can record the jaw relation record, and after finishing the jaw relation record, I can scan it and remove the screws after finishing. So now I'm having a fixed screw retained occlusion block, and really this is a very precise way of doing the work. If you are like a crazy guy who believes that I need to track the whole motion path, you can do this. You can add a tracer to your occlusion block. The tracer is actually a very simple file. You can add it to your occlusion block, which is a plate, essentially a plate, and a screw, an adjustable screw that can move up and down to adjust the vertical dimension. And you can print them with the occlusion block, fix the occlusion blocks with the screw, so now it's fixed. And all what you need to do is that you adjust the level of screw up and down until the vertical dimension is the same. This part is equal to this part, and eventually the patient bites. And when the patient bites, I ask him to move front and back, right and left. And when the patient does so, he's just drawing what we call the Gothic arch. This is the Gothic arch, and the tip of the Gothic arch is actually the centric position. So with the patient at this point, I might maybe make a dimple in this part and ask the patient to bite. And the patient biting on this part, I would just scan the occlusion block from the right and left, and now I'm having the bite for the patient. And this is actually the most reliable way to do it, but it's a little bit complex, requires some skill from the operator, requires some special gauges to print. So in brief, I would love to use my temporary bridge if I have it. If I don't have it, I would go for an anterior deprogrammer using the green stick or the special gadget I showed you. If you don't know how to do this or this, you can always go back to printing an occlusion block, take a conventional jaw relation record with tissue supported or maybe an implant retained occlusion block and scan it, and everything goes digital from this point. I'm really thankful for having me in this webinar. Those are my contacts on the Facebook, on the Instagram, and this is my YouTube channel for you'll find a lot of very nice tutorial videos for implant planning, some design processes, so you can check it to see if it's free for everyone to check it and know about it. So I would like to thank you all. This is our Cairo Implant Academy. It's in the heart of Egypt, dedicated only for implant training from all over the world. We would like to have you someday in Cairo to share knowledge with each other. So thank you very much for having me in this nice event, and I'm ready for any question if you want to have some question. So thank you. Okay, now I'm having some questions, probably a few questions to answer. The first question, which is really a very good question, is about photogrammetry. The concept of photogrammetry is a little bit difficult. Most of the scanners we have in our clinics are called active scanners. They are sending like a pattern of light, and this light hits the object, the tooth or the soft tissue, and it reflects, and the cameras inside the recording the distorted image. This is very good with detecting things with very high resolution, like the margins, the preparations, and whatsoever. The photogrammetry is a little bit different. The photogrammetry depends on what we call passive scanning, where there's only a camera that are taking 2D images, whether extraoral 2D images or intraoral ones. And we utilize something called target-based photogrammetry, where we have markers over the scan bodies. And really, photogrammetry can be considered the gold standard. If you're asking me what's the gold standard in implant scanning, it's target-based photogrammetry. And the problem with photogrammetry, whether the extraoral or the intraoral one, that for the extraoral photogrammetry, which is the old gold standard, you need also an intraoral scanner to augment the data for the soft tissue and the bite and the other things. And the scanner is really very expensive. For the intraoral photogrammetry, which is the new gold standard, if you can say so, it's a separate device that can do both functions. But the aim of this lecture was to tell you, if you are using an ordinary scanner, how can you optimize the scan to get results that are close to photogrammetry? Let it sum it up. I'm doing a lot of research regarding this. I'm comparing extraoral, intraoral photogrammetry, regular scanner with different types, different splinting techniques. And let me tell you the differences. The intraoral and extraoral photogrammetry produce an accuracy in the full arch scan around 5 microns. We have like a discrepancy of 5 microns. With the regular scanner, without doing any splints or anything, it's around 30 microns. What we can do with good splints like the central and the radial one I discussed in the lecture, we can drop down the accuracy probably to 10 or 15 microns, which is fairly good. So I'm just telling you, if you don't have a photogrammetry device, because you're not doing a lot of implant cases, this is not your main territory to do it every day, you can use your regular scanner with the proper scanning protocol, and you can get very good and fair results. And this brings me to the next questions, which is sort of a commercial question a little bit, which means someone is asking, are certain scanner technology better suiting the full arch? I'm telling you, if you are not using photogrammetry and you're using active scanners in the market, if you asked me this question like 5 years ago, probably I would tell you probably like 2 or like 3 scanners can only do the job. But now, believe me, the hardware differences between the different scanners is getting very close. The differences are not very big. And probably with most of the scanners in the market, if you follow a good strategy for scanning, as we discussed in the lecture, you can get a decent scan for the full arch. But really, there are some features that would help you. Number one, which is the most important, is your computer, the hardware. And this is why I'm telling you, you might need to invest in the hardware, mainly the processor and the graphic card of your computer, because when you have good hardware, the processing of the image is faster, the algorithm is much better, and the scanning speed and quality is much better. So invest in your hardware computer. Number two, the softwares of the scanners are not the same. Some scanners are having some features that help you. Probably you have seen in the lecture, it's a very nice feature. We used to, in the old days, probably like a few months ago, we used to scan the soft tissue first, and then we go scan the scan bodies. And we have an affection from the soft tissue scan because of the movement of the soft tissue. A very nice feature I would like to have is that if my scanning workflow allows me to scan the scan bodies first, and then I can scan the soft tissue. This is very good. The second feature is the AI matching of the scan bodies. The softwares that allow us to AI match the scan body and replace it with a numerical one are really very nice plus. Number three, the ability of your scanner to filter the movable soft tissue. This is very important when scanning full arch cases. So if you have this feature in your scanner, it would be a plus. And I would like to have a scanner that gives me the ability to provide like an extra scan. Maybe they call it an extra mesh or an additional scan, because when having such a scanner, it can help me with a very difficult situation, maybe to scan like a fitting surface of the impression for the soft tissue, maybe scan like a preoperative model for the patient. This would help a lot with either the jaw relation record or scanning of the soft tissue. So probably those are the main features I would like to have in my scanner. But believe me, the hardware differences are getting very close, and it's becoming like a commercial thing between companies. It's not really impacting the final outcome of the scanning. A third question is talking about do you have a backup plan if your scan fails intraoperatively? I really don't understand the question too much, because probably I haven't had a case that I couldn't scan in the past few years. Because any limitation in the scanning is actually a limitation for the impression making. But if you mean that, sometimes in very few cases, if you follow the good protocol, you would have a passive fitting framework. But if you have a non-fitting framework, maybe a try-in that's not good, you don't have to rescan the cases. All what you need to do is to cut the try-in, the temporary, the PMMA try-in, cut it, screw it over the implants, and you scan the new position of the try-in. And then the lab can reassemble everything together and give you a decent scan. So if you mean by failure a non-passive one, probably this is the way. But I don't believe nowadays that I'm having a difficulty in a full arch scan that makes me quit and go to other factors. I would not do that. The next question is about the bite registration. Yes, in all bite scenarios, you have to record the centric and the vertical. If you're using the preoperative temporary, if you're using just an anterior scan body or whatever, yes, you have to record the centric with one of the ways I showed you and the proper vertical. Someone is asking about the prime scan. The prime scan is a very good scanner. You can use it, but definitely, you cannot use it alone, especially in the mandibular cases with long spans. So the splinting or the different scanning techniques still applies, although it's a good scanner in scanning the soft tissue and the implants. Someone is asking about the bite registration material, a replacement for the green stick. The green stick is the best because it's hard. The second one is probably a bite registration material, which is hard enough. I don't like pink waxes and I don't like silicone. So I believe the best one to create a deep programmer is the green stick compound or the impression compound cakes. Someone is asking about which scanner is a good for implantology. I told you, scanners are really becoming very close to each other. Probably a decent scanner in the market, not the very cheap ones, the entry level. Any of the scanners in the market with a good strategy, a good computer would give you very good results. I can conclude now. Thank you very much. I think we are on time now. Thank you very much. And you can contact me on either of the contacts on Instagram or the Facebook for further questions or further support. Thank you very much for having me today in the DT Study Club.
Thank you to Professor El Kadem for clarifying scan strategies in All-on-X workflows and for guiding us through real procedural steps. We'll reconvene shortly for the next session. The next session, Understanding Implant Stability in Immediate Therapy, the role of RFA in highlighting the dynamic process of osseointegration, offers insight into how insertion torque and ISQ differ, and how ISQ trends over time can more meaningfully reflect the transition from mechanical stability to biological integration. Dr. Michael R. Norn will also introduce how the Ostel Connect platform can be used longitudinally in this context. This is a must-attend session if you want to better understand how to optimize loading decisions based on stability metrics rather than torque alone.
Well, hello, and first of all, let me start by thanking Ostel for asking me to share my thoughts and for taking part in their webinar series in collaboration with Dental Tribune. My subject today is resonance frequency analysis, the only longitudinal metric for implant stability in immediate implant therapy. And this is a subject that I have been publishing and lecturing on for quite some years. So as time goes by, we try and refine and further understand the ideas that I've been putting forward, because there's always a risk of ideology when it comes to particularly implant dentistry. I think we all recognize that whether it's about choice of implants, whether it's about choice of implant connection or surface or whatever, there's a lot of ideology, and ideology really translates to opinion that is not often supported by the evidence. So I would like to start by defining the term epistemological view as it pertains to secondary stability, which is in fact the thing that we should be most concerned about, not primary stability. We're not carpenters, we're clinicians. and the goal of implant dentistry is osseointegration. So let's first define epistemology. This is defined as an investigation of what distinguishes justified belief from opinion. So the first thing to say, and we can dive straight into this, is that currently, other than ISQ, assessment of secondary stability is based on a belief that is founded on purely subjective faith. Why do I say that? Well, of course, insertion torque, which is the key metric for primary stability, is of no value to us in assessing secondary stability. You can only measure primary insertion torque once at time of insertion. So it is a one metric, one time only measurement. Other measurements that we would use that could be considered objective probably are limited just to the perio test, but because this is considered a potentially destructive measurement, it has fallen out of favor. So that leaves purely subjective faith. You can try and use the metallic percussion sound, or you can use the absence of perceived mobility or pain, but these give very little detailed information about the dynamic change from primary to secondary stability. And certainly a radiograph gives absolutely no information about the dynamic change from primary to secondary stability. So we need to reassess what our goal is. Today, as I say, it seems we only really talk about primary stability. It absolutely dominates conference halls. It dominates the sort of marketing blurb that implant companies put out there. And in fact, it dominates implant design. But it doesn't necessarily give rise to optimal surgical protocols or optimal implant designs that give rise to a high quality secondary stability. And this is what counts. So let us remind ourselves that there are two phases in the healing of an implant, from the moment of insertion to the point of restoration. That healing phase is demonstrated in this now quite famous graph by Raghavendra et al., showing the green line at the top, which represents the shift from mechanical primary stability to biological secondary stability. And we know that over roughly 3 weeks, we will see a drop in the primary stability and a slow but gradual increase in the biological or secondary stability. And this has typically given rise to a dip in stability around the 3 to 4 week period when an implant is at its most vulnerable. So what about torque? Let's talk about torque. And let us first of all define torque as a force that tends to cause rotation, and it's scalable. It can be measured in Newton millimeters, it can be measured in Newton centimeters, or in Newton millimeters. And of course, we are focused around the Newton centimeter range. The interesting thing about torque in implant dentistry is that all implant companies have a manufacturer's recommended insertion torque for devices that are essentially of a very similar geometry, of a similar design, being placed into human bone. And although there are, of course, differences in the elasticity of human bone from site to site, from jaw to jaw, and from cancellous to cortical bone, I think it's not unreasonable to say that as a broad brush statement, one would assume that there would be a relatively tight range of insertion torque around which the industry would coalesce in an understanding that maybe too much compression on the bone might be a bad thing. So here you see one torque driver, and the recommended insertion torque is 25 Newton centimeters, and the scale runs from 0 to 45 Newton centimeters. By contrast, here's another torque driver where the scale doesn't start until 50 and goes up to 90. And this means that there is a safety zone, according to this torque driver, where torques below a level of 50 may yield instability. So it's perplexing, and has always been perplexing to me, that you have some implant companies telling us that we should stick to within a maximum of 50 Newton centimeters or even less, and then you have others that won't even start to consider successful primary stability until above 50 or way above 50 Newton centimeters. So we need to understand what's going on here, and we need to clarify, as clinicians rather than carpenters, what is best for bone, what instigates the best healing, the best osseointegration, and long-term maintenance of marginal bone, which has to be the goal. Now, I had already done work on this in the early part of the 2000s, but by 2013, it had become such a pressing problem in my mind that I published an editorial in the International Journal of Oral and Maxillofacial Implants addressing this very subject. Indeed, I was perhaps naively so concerned about the use of the term primary stability that I tried to suggest that we change that term to something that was more relevant biomechanically speaking. And so I proposed the words viable constraint. By that I mean that the implant is constrained in the bone, but that the bone itself remains viable, i.e. it remains alive. And so I felt there was a need to redefine. And in this editorial, I presented, I believe for the first time in the implant literature, a slightly simplified mathematical formula for resistance torque, or what most clinicians call insertion torque, but correctly termed resisting torque in the world of engineering. And you'll see here that that torque is directly proportional to the coefficient of friction of bone in this case, directly proportional to constants such as pi, and proportional to the height and diameter, or the length and diameter of the implant. But of the two, you will see that the diameter is a far more influential factor, as it's to the power of 2. But it's also proportional to something called P, the critical pressure on the bone. So due to that proportionality, you can understand that as the insertion torque increases for a given implant of a given length and diameter, where pi and mu are constant, so the critical pressure on the bone must increase. And this indeed is what we see, and has been demonstrated through many finite element studies, but perhaps far more relevant and notably through histological and histomorphometric and biomechanical studies. And we must recall that histology does not lie. So if bone is damaged, we will see the histological effects of that. And if bone is not damaged, we will equally see the histological effects of that. In a study by Treasy et al., where they compared high insertion torques of in excess of 100 Newton centimeters to low insertion torques as low as 10 Newton centimeters, they found some interesting things. First of all, they found that there was no correlation between the insertion torque and the implant stability quotient as measured by resonance frequency. Now, this is one of literally dozens of studies that have shown a lack of correlation between torque and ISQ. And so the first thing to understand is that if there is no correlation between torque and ISQ, but yet at the same time they both claim to be measuring primary stability, then by definition, one of them is wrong. One of them is measuring primary stability and one of them is measuring something else, and hence they don't correlate. In this study, they saw that change in ISQ over time was small, but with a slight decrease noted in implants inserted with high torque, but an increase for those implants inserted with low insertion torque. And of course, we understand in the world of resonance frequency that we're always looking for a gain in ISQ. In other words, that stability increases from primary through to secondary stability. What they also noted in this study were that there were microfractures within the bone when high insertion torque was used. And they state that whilst there was no histological evidence of necrosis, there was nonetheless a significant loss of primary stability recorded for implants with high insertion torque. Such loss of stability was not seen in implants inserted with low insertion torque. They assumed that this was the result of the viscoelastic properties of bone. When looking at bone to implant contact, at first sight, it would appear that implants with high insertion torque, shown in the blue here, don't seem to lose any bone to implant contact. By contrast, implants with low insertion torque, which started with a low bone to implant contact, see a very rapid and significant increase in that bone to implant contact between 3 and 4 weeks, which you'll recall from the Raghavendra curve is when we change from primary through to secondary stability. And when we look at the slope of these curves, we see actually that there's a steeper curve for implants with a lower insertion torque. And this is borne out regularly by changes in ISQ when we look at implants with a higher ISQ at placement. The curve flattens compared to implants placed with a lower ISQ. But when we look at loss of stability, you can see that implants with a very high insertion torque actually appear to lose 50% of their stability over the healing period, whilst those placed with low insertion torque seem to have a 4-fold increase in stability over an equivalent period of time. And actually, the amount of stability, while it seems to be higher in the high insertion torque group, there is little significant difference. So again, we see a very dramatic difference in the response of biology to high versus low insertion torque. And we can see this in the histological specimens themselves. So these are taken from Treacy's study. In the high torque group, we see initially in week 1, we see the microfractures in the cortical bone. And by week 4, we see a quite significant resorption process. So this is a classic remodeling equation of trauma leading to resorption, leading to bone loss, leading to remodeling, and hopefully apposition of new bone. But even by 6 weeks, you'll notice, although they've labeled this as woven bone, this would be characteristic of the classic saucerization or crater formation down to the first or second thread that we have typically seen over the years with implants, and that, of course, Albrechtsen way back in 1986 described as an adaptive response by the bone to healing. In this study, Treacy et al. Actually chose to include this woven bone contact as part of the bone to implant contact. I would argue this is a little disingenuous because, as we all know, woven bone may or may not be sustained over the long term. And so it's very possible that this woven bone will actually disappear over time. And if so, there would have been a much more significant drop in the bone to implant contact. By contrast, in the low torque group, you might argue it's also a little disingenuous because, as you can see from the specimen here, there is a huge gap between the bone and the implant, almost only contacting at the base. And so it's not surprising that they all started with such a low bone to implant contact. However, there is a huge difference because at 4 weeks, what we see here is not resorption because there was no bone in this space. Rather, this is de novo bone formation, neobone forming within the coagulum, bridging the old bone, the edge of the osteotomy, to the surface of the implant. And whereas by 6 weeks in the high torque group, we still had a mass of woven bone, in the low torque group, we already have full maturation to lamellar bone reaching the surface of the implant. So these couldn't be more contrasting pictures. And this is also supported by work from John Brunsky's group in Stanford University in the United States. Cha et al. Published this multi-scale analysis of the bone to implant interface, comparing high and low insertion torque again, but now they're looking in far greater detail. They're not looking at histology, rather they're looking at the cellular response in terms of death or not, in terms of the molecular response, in terms of cell proliferation, bone strain, microfracture damage, vascularization, bone formation, and stiffness. So it's a very comprehensive analysis. And what they conclude is that the data presented demonstrates that high insertion torque generates strain in the peri-implant bone that is detrimental to osteocyte survival. High strains constrict blood flow, cause microdamage through fracture to the peri-implant bone, which of course we saw in the Treasy study. And all of this contributes to osteocyte necrosis, extensive bone remodeling, and minimal new bone formation. So there is a resonance here between these two studies, even though they're looking by different methodologies. Although implants inserted with high insertion torque may exhibit primary stability, and this is perhaps one of the most amazing statements to have been made in implant dentistry in the last decade, their ability to achieve secondary stability is uncertain. Now, I would take exception to that because we do know that implants placed with high insertion torque osseointegrate. And there was a study by a friend of mine, Philippe Kayat from France, where he used insertion torques up to 175 Newton centimeters and still showed that the implant could osseointegrate. The problem is that we think of osseointegration as a binary concept, and I'll come to that in due course. But what we do know, and you know, the internet is replete with radiographs like these, that if you abuse bone, if you overly compress the bone with excessively high insertion torques, then you will get a reaction. And at the very lowest level of reaction, you might get some sorcerization and marginal bone loss, or maybe not even initially that you would see that, but established over the first, say, 2 to 3 years, you will see sorcerization and marginal bone loss. But at the extreme, you will see complete pressure necrosis around the implant. The implant will be quote unquote rejected with an extremely painful and suppurating infection. So this is a problem, and it's also a problem that we see particularly in the dentolegal world, that lawyers have grasped onto the nettle of peri-implantitis, and they are making it very clear that these are all examples of peri-implantitis. Nothing could be further from the truth. These are all examples of trauma to the bone. They have nothing to do with biofilm, and it is a natural response of bone to excessive compression or excessive strain under high insertion torque. They may create niches into which subsequently peri-implantitis can be established through the biofilm, but the bone loss comes first. And I am convinced that if we are seeing an epidemic of peri-implantitis, as some would have us believe, then it is because we also have an epidemic of high insertion torque being used with aggressively threaded, highly tapered implants, such as the ones you see in these radiographs. So I would say that most clinicians fail to appreciate the threshold sensitivity for primary stability, as well as the viscoelastic limits of vital bone. The most important take-home message is to understand that there is a threshold for primary stability, above which increases in magnitude of insertion torque do not yield increases in primary stability. They simply damage the bone. And this is where we come to the role of resonance frequency, which provides us with a far more sensitive and specific objective measure of both primary and secondary stability. And so it's a tool that allows us to map the change in stability. It allows us to record the journey of an implant, you might say, as it osseointegrates. The ISQ, or implant stability quotient, measures lateral stiffness as compared to torque, which of course we've said measures resistance to rotation. Clearly, lateral stiffness and resistance to rotation are not the same thing, and that is why these two metrics are not correlated, and that is why I believe and have believed since the introduction of resonance frequency that this is the true measure of primary stability. It is measured on a scale of 1 to 99, but I would say the clinically important range is probably somewhere between 50 and 85, where measures above 70 are considered to be equal or equivalent to clinical osseointegration. Obviously, if you measure that number at placement, it's not osseointegration, it's just high mechanical stiffness. But once you seek follow-up measurements, if you're over 70, then that would suggest osseointegration. And we know that this measures a curve that if you took enough measurements, sort of maybe not daily, but certainly every few days or every week, you would trace a curve much like this, which again, Raghavendra showed us represents, if you like, the heartbeat of change in stability as we lose mechanical stability due to the resorption and remodeling process, and then we gain biological stability through osseointegration. However, what we also understand from the histology that I've shown you is that if you ratchet up the torque to in excess of 50, or as some torque drivers would have us do, up to 90 Newton centimeters, then we know that we change the secondary stability curve, which becomes slower to heal, may result in inferior bone to implant contact, and therefore may result in a drop in ISQ over time. And that is not what we're looking to achieve. Of course, we understand that other factors play a role. So we understand that there are different bone qualities that have been highlighted initially by Leckholm and Zarb, and then in 2001 by myself and Carol Gamble, and also the Misch classification as well. So we know that ISQ, we know that insertion torque can both independently be affected by the quality of the bone, as well as, of course, the surgical protocols, such as under-prepping or over-prepping the osteotomy. But if you look at all of these curves, they all show that remodeling leads to a loss of primary stability. So how do we avoid the dip in the curve? Well, the answer is, first of all, through implant design, but that's not really the remit of this lecture today, other than to say that if you use increasingly aggressive threads with an increasingly tapered implant, you will increase the torque and therefore increase the compression on the bone. But that set aside, there are other things we can do. We can use lower insertion torque. We can do that by maybe creating more, what's the word I'm looking for? More matching osteotomy to the dimension of the implant, rather than under-preparing, and certainly not using things like VersaBurs, which, by the way, compress bone debris against the wall of the osteotomy in order to provide that enhanced stability. I would rather that than high insertion torque. But for those of you that use VersaBur, be very aware that that bone debris that it condenses against the wall of the osteotomy will itself resorb. It is by definition dead bone because it's bone debris. So that will resorb. And so you have to ask yourself, in a case of immediate loading, particularly for a single tooth implant, what happens at 3 to 4 weeks when you start to see a dip in the stability of that implant, especially if the patient inadvertently starts biting with it because they've forgotten the rules you gave them at time of placement. So when we use a more favorable surgical protocol with a lower insertion torque, we start to see more favorable ISQ curves, and we start to see a gradual loss in the dip at 3 to 4 weeks. This is a particularly interesting curve that looks at micromotion, and we could overlay ISQ values on this. This is from work by Pagliani, and we understand that since ISQ measures stiffness, the more micromobility there is, the lower the ISQ. And as the micromobility decreases, so the ISQ increases. And the region that's of greatest interest is, of course, the elbow here, because you can appreciate that once we get round the elbow, further increases in stiffness yield very little change as the curve effectively plateaus. So once we get above 70, nice though it is to see values of 80 or 90, which is very rare, you can see that actually the change in stiffness is very limited. So the question we need to ask ourselves is, what kind of an insertion torque are we looking for to get us around the elbow of this curve? Well, I set out to answer that question a few years back. This article was published in 2017, The Influence of Low Insertion Torque on Primary Stability, as well as looking at survival and marginal bone levels. It was really a proof of principle study. The first thing I'll say is, as a corroboration to the work that we saw earlier by Treasy, you will see that when we start with high ISQ, the curve is very flat. But when we start with very low ISQ, the curve is very steep. And this correlates well to what we see also with insertion torque, that if you crank in an implant with very high insertion torque, you will not see an increase in ISQ. On the contrary, as Treasy showed, you will probably see a decrease in ISQ because you will have a wave of resorption, a reduction in the bone to implant contact, and possibly a reduction in what I call the quality of osseointegration, which I will address. So when we look at the results of my study, I'd like to show you the relationship between ISQ and torque. This graphic legend is not quite right, so I apologize. The 100 should be up here, so everything needs to shift up a bit on this graph. But anyway, the principle of what I want to show you is this, that when we look to the left of the black line, we see a very wide standard deviation, or to put it another way, a wide variability in the ISQ, both at placement and even at secondary stability. What does this mean? This means for super low insertion torques below 10 Newton centimeters, we cannot guarantee not only an adequate primary stability where there are these wide deviations, but perhaps we can't even guarantee good secondary stability. But these are spinners. These are implants that are not only not resistant to rotation, but they also may be not resistant to axial stiffness. They may not have axial stiffness. So you see here, some of these ISQs are at 40 or below. However, it's very interesting that when we get above just 10 Newton centimeters, which is finger tight, not even finger tight, 12 Newton centimeters is finger tight. But when we get above 10 Newton centimeters into the finger tight range, suddenly we see the variability collapses, and the standard deviation, or the error around the mean value, is very, very small indeed. Small for primary stability and almost non-existing for secondary stability. What does this tell us? This tells us that for insertion torques above 10 Newton centimeters, you can basically guarantee an ISQ in the sort of 65 to 70 range, and that those implants will go on to integrate in the high 70s to low 80s range. And that this is pretty much guaranteed because the variability is so low. Now, of course, I'm not saying that the threshold that we can work to is only 10 Newton centimeters. I think that would be irresponsible of me. But what I do think we can say, and what I said way back in that editorial in 2013, is that we can say with a great deal of confidence that the threshold for primary stability is definitely no higher than 20 to 25 Newton centimeters. Indeed, if I were to give you 5 implants at 25, 35, 45, 55, and 105, you couldn't tell me which was which. They would all feel equally tight to you if you tried to test them manually. So it seems to me that on this curve, the threshold probably is around 20 Newton centimeters if we want to be safe. And that means we don't need to use higher torques than that to get success. And I have published numerous studies to show this. So in my editorial in 2013 on viable constraint, at that time, I was talking about a threshold of 25 Newton centimeters and or an ISQ greater than 60 for safe immediate loading. And in the subsequent 12 years since I published that, I see no reason to increase those numbers. And indeed, there may be an argument to decrease them. Although, when I am lecturing, as I am to you, I will typically talk about 25 and an ISQ of 65 in one direction. So the thing to understand is that osseointegration is not binary. This idea that there is just 2 options of success and failure is entirely wrong. Osseointegration is not binary. There are an infinite range of qualities of osseointegration, just as Treasy basically showed in those histological specimens. But how do you know what quality of integration you have? You can take lovely X-rays and show excellent marginal bone maintenance, and marginal bone levels still remain a primary metric for success. And you can combine that with superlative soft tissues, with an absence of pocketing, to know that clinically you have success. But what this doesn't tell you is what the journey of those implants were in regard to stiffness in bone, in regard to comparing primary stability to secondary stability, and even furthermore, stability subsequent to some degree of either definitive load or progressive load. And this is where ISQ and the Osdell Connect, which is now readily available online, really comes to the fore, because Osdell Connect is an auditing system that allows us to record our ISQ measurements, and you can see that since I've been using it, I've got nearly 1,500 implants on here with over 800 patients, 477 of which are active, and over 3,000 measurements. And we can start to see the range of ISQs. Obviously, something's gone awry there because that's extremely low. But we can see a placement and final restoration, and we can compare immediate and conventional loads or early loads, and we can see actually that there's very little difference between them. We can look at different situations. So we can look, sorry, let me just go back there. That's single tooth, I should say. So that was all data, and that's single tooth. And in fact, we can see, if anything, that immediate load primary stability as measured by ISQ was better than perhaps multiple implants. Okay, I want to show you a typical example. I typically only take two measurements. I take one at placement and one at 3 months prior to definitive loading. And if I see a curve like this with a very nice slope going, in this case, from 53 to 75, there really isn't a need to take additional measures. We know that the journey for this implant is one of high quality osseointegration, because we've gone from low primary stability to high secondary stability. Sometimes, though, we see less of a change, and this would be an example of a case where I can say I haven't lost stability, but I haven't really gained much stability. And in some of such cases, I might look to progressively load the implant to see if I can see an uptick in the stiffness of the implant over time. So in a case like this, for example, you can see we started with a low ISQ of 57. This was December 21. By March 22, so 3 months, it has gone up, but not very much. So we measure it month by month, and we see gradually this is going up to 69. Then it seems to dip again. And so we can continue to map the journey of an implant in such a way. Equally, we can see decreases, and this was an example of an implant where I got much higher insertion torque than perhaps I would have liked. And so in an effort to avoid this, I will typically, if I get insertion torques above 45 Newton centimeters, I will back out the implant, allow the viscoelastic bone to rebound. The implant will have effectively acted like a bone tap. I leave the bone for a few moments just to rebound and relax, and then we reinsert. But you will still get an effective resorption and perhaps a reduced quality of integration as a result of the initial damage from the high insertion torque. This is an example you can see here, lower right molar, where we've got quality 1 bone. I've used every drill at my disposal, and in fact, at this case, we were way above my preferred level of torque, close to about 75 Newton centimeters, and we paid a big price for that. The interesting thing, though, about this implant and implants like it is it is resistance. It has resistance to removal torque when you unscrew the healing abutment. The patient has no pain. The soft tissues are healthy. The radiograph looks normal. And by all other subjective metrics, you would assume this implant was perfectly successfully osseointegrated. But this is an implant that is storing up a potential for marginal bone loss and peri-implantitis in the future. So let me give you a quick example of a case before we wrap up to show you that when you believe in this protocol and you are not obsessed with high insertion torque, you can treat some really very demanding cases. So here we have a patient with a very sizable cyst related to the upper right central incisor that had been subject to trauma when he was a child. And if we look at this cyst, we can see it measures 1 centimeter by 8 millimeters. So it's quite advanced, and it's also enveloping around the patient's lateral incisor, and this tooth has a hopeless prognosis. So we plan for an implant, and believe it or not, we plan to do this on an immediate same-day basis. Why? Because number one, he does have some basal bone into which I can retain the implant. And so long as I get an insertion torque of 15, 20, 25 Newton centimeters, I'll be happy. We have a robust plate of buccal bone, which means that it's favorable to immediate insertion. And in my experience and from all my work and my studies, I believe that you get a far better maintenance of hard and soft tissue architecture if you do immediate placement and restoration. So here we go. We have a surgical guide. We've extracted the tooth, and we've also made a semilunar or horizontal incision above the mucogingival line. So we are not touching the keratinized mucosa around this bridge of bone at the crest of the ridge. So we can enucleate the cyst, we can debride and decontaminate this very large infrabony defect, and we can also visualize the placement of the implant through that defect using our surgical guide to ensure that the implant is in the right position. We can then effectively graft that defect, and we can take our ISQ, and as you can see at baseline, we have 61 and 65, so I fulfill my criterion of greater than 60 or greater than 65 in one direction, and I even have an insertion torque of 20 Newton centimeters, which in today's world most people would consider ridiculously low, but as my 2017 study shows, it guarantees the stiffness of this implant, which in turn should guarantee osseointegration at a high level. So we cover the graft with our membrane, and we suture, and I've placed an under-contoured immediate temporary crown to hopefully bring the soft tissues down around the neck of that implant. And then we track we map the journey of this implant. Placement was in 2024, April 2024. 3 months later, or 2.5 months later, we see very little gain in ISQ. So, of course, with an implant like this, you have to be very careful if you're going to measure ISQ very early. So I would say 2.5 months was the earliest. We then leave it for another few months, and by now we see a very dramatic increase in ISQ. And what this is telling me is a number of things. First of all, it is telling me that the apex of the implant in the native bone has certainly osseointegrated, but more importantly, over a period of 5 months, it's also telling me that my bone graft has consolidated and probably osteoconducted bone to the surface of the implant within the defect, because that's the only way I can really explain such an impressive ISQ. We then monitor it post-definitive restoration out of interest, and you can see that once we get to just under a year later, we're at 84, and 6 months after that, or 5 months after that, we're at 86. In other words, the stiffness has plateaued. So this is the complete journey of this implant and the graft around it, showing a high level of osseointegration, both within the graft and within the native bone. And this gives me every confidence then that I can see this implant with its more favorable soft tissue profile survive over the long term with a really impressive marginal bone level and a bone graft that is almost invisible radiographically. And so this is really what we want. And you cannot do that using a single time measurement like insertion torque. So the important singular benefit of resonance frequency is to repeat measurements over time and infer the dynamic biological changes that take place during healing with objective proof of the healing process of osseointegration, allowing the clinician to restore at the most appropriate time and with greater confidence. Since it's not possible to repeat the measurement of insertion torque, which is a one measure, one time only metric, and therefore provides no longitudinal information about the dynamic process of osseointegration whatsoever. So for me, it's very clear which of these two represents an appropriate instrument or metric for primary stability. By using this so-called curve of stability, it's possible to customize the treatment journey for each implant in every patient. And so with that, I thank you for your attention and welcome any questions. And if you want to, you can also email me at drnorton, drnorton, at nortonimplants.com. Thank you. I hope you all enjoyed that presentation, and we've actually got a few questions that have been coming through, so I'm going to try and address some of those questions. A couple of the questions kind of pertain to the same thing, which is sort of calibration questions, and sort of asking whether you have to calibrate the peg for different implant surfaces, different implant angulations, and the reliability of those. So these questions go to the very heart of the problem, that is that we mustn't think of ISQ numbers as a one-time reading, as a once-only metric. The value of Ostel and ISQ is not in a single reading, but rather in the comparison of multiple readings. Could just be two readings, but so, for example, if you have angulated implants, it doesn't really matter that they're not straight. You will get a baseline value at time of placement, whatever that value is. And if you then retake the ISQ at a later date, you then compare that reading to the first reading. And that's really the big difference between resonance frequency and insertion torque. You can only measure insertion torque once. And I think the big problem with our profession in terms of understanding the value and the meaning of ISQ is that most people still think of it in the same terms as we think of insertion torque.
So we have to get out of that mindset, and we have to think about the fact that you're not comparing different implants or different implant surfaces or different thicknesses of bone, different qualities of bone, whatever it is. You're comparing one reading to another on the same implant. That implant presumably has, by definition, the same angle, the same surface, the same bone around it, hopefully, which leads me to another question, which was about marginal bone loss and whether there's any correlation between ISQ and marginal bone loss. And the answer is yes, there is. The sensitivity with which it'll pick up that marginal bone loss will somewhat depend on how thick that bone was to start with. So if you actually had quite a thick bone, and let's just say for the sake of argument, I don't know, maybe the patient got a poppy seed or something impacted under the crown, and that caused a big infection, which ultimately led to bone loss of what was originally good thick bone, then you would clearly see a change in the ISQ. Of course, if the crestal bone was not there to start with or was very thin, and then you see some marginal bone loss on an X-ray, you may find it's not sensitive enough to discern the difference necessarily, or it may take more bone loss before you can discern it. A question that's come from a good friend of mine, and I'm very glad to see that he's busying himself looking at me lecturing rather than maybe being on the golf course or something, is from my friend Israel Ismaj. And he asks a really good question, and it's not a planted question, but it's a good question because it's something that I'm discussing and talking about more and more. That is, his question is, if we insert an implant into an extraction socket, could be a molar site, frankly, it could be an anterior site, and we graft the gap around that implant, can the ISQ give us some insight into not just the integration of the implant, but also the consolidation of the graft and whether the bone gets through the graft to integrate with the implant? And I've been looking at this more recently because it's certainly something that interests me. And the answer, Israel, is actually, if you use ISQ, it's actually quite amazing how it'll track the consolidation of the graft. So maybe you place the implant, you compact some, I don't know, BioOS or whatever your graft material is around the implant, you take a baseline reading, and it's only, let's say, 60 ISQ. And then you go back at 3 months and you find that it's definitely gone up because the apex of the implant that's in the native bone has probably osseointegrated. So now maybe the ISQ has gone up to 68, or maybe it's even gone up to 70. But if you keep tracking that implant, even though 70 would be like a pass mark and you might go to definitive restoration, if you provisionalize it and you keep tracking the implant over another 6 months, let's say, you will see the ISQ tick upwards from 70 to 74, 76, 80, whatever. And the only way that can happen is not by that little bit of apical implant that was already integrated, somehow integrating more to give an increase in ISQ, but rather because bone has grown through the graft and consolidated the graft and integrated to the surface of the implant. And in those circumstances, you see this very clear progressive increase in ISQ. And to that point, I would say, as I said in the lecture, that this is about really having an appreciation for the dynamic processes that are going on around the implant. And frankly, resonance frequency is the only way you can do that. So another question, what are the current limitations of RFA that you hope future developments will address? Oh, that's a very good question. It's a difficult one, I suppose, in some respects. What are the limitations? There aren't really any limitations. Sensitivity might be an area. If we could make it that much more sensitive, maybe it would be able to identify more subtle changes over time. But I would argue that it's already more notably sensitive than, say, for example, implant mobility, which of course is an extreme. And we have to understand that osseointegration, again, it's not binary. Implants don't just succeed or fail, which is what a mobile implant will sort of assess. Rather, it's a range or a quality of osseointegration. So I'm not sure about future developments. I think as a system, it's very good. I think a lot of people would say with Ostel, they'd like to have reusable pegs rather than a once only. Other systems do reusable pegs, but for me, that's the whole point. So those are basically the questions. There was another question, let me just have a look here, about the influence of soft tissues. Effectively no influence. The ISQ is really measuring the stiffness of the implant in the bone. I think it's hard to envisage that the soft tissues got any influence over that. And also bear in mind that if you're placing a peg at implant level, then you're placing it below the level of the soft tissue inside the endosseous implant. If you're using abutment level pegs, then maybe that question would be more pertinent. But even at abutment level, given the stiffness of metal, I find it difficult to imagine that soft tissue will have any influence. And then I think the last question before we wrap up was about platform switching. I didn't really understand the question. All I can tell you is that most implants today are now moving to an internal conical connection. And of course, by definition, they're all platform switched. So, because an internal conical connection always sits inside the shoulder of the implant. So I wasn't really sure what that question was getting at. But anyway, some great questions there. And one last one I just see. What's the optimal torque for the peg? I think the recommended torque is actually only 5 Newton centimeters. So that's light finger tight, not using any ratchets or heavy handedness. It's light finger tight. Okay, so I think that's everything, Diana. Clock, so we're done.
Many thanks to Dr. Norn for walking us through implant stability and how RFA can inform clinical decisions in immediate therapy. Stay tuned, the next session is coming up soon. Up next is the session From Extraction to Implant, Just Shield It. Dr. Krzysztof Chmielewski presents strategies for ridge preservation using the Novamag Shield technique. Join to learn how this novel biomaterial may provide a streamlined, predictable path from extraction to stable implant support.
Hello to everybody. My name is Chris Milewski, and I'm really very happy to share with you my experience related to magnesium membrane, which is called Novamag, which comes from Botis company. And I'm really very happy that I can share experience, which is right now over 2 years. We are using this membrane, and it is just very interesting material from the options which it gives to you. So it's membrane by itself is a piece of metal membrane, and from the beginning, when I noticed or got information that Botis is working on this material, I was very much interested, because this is metal but resorbable membrane. So from the side view, you can realize that it's very, very thin, very small. It's flexible. You can shape it, and it has a lot of indications actually in the office. And on the early beginning, when I looked into the materials and which direction Botis is going with this shape, with this membrane, we were thinking to use it in different indications. And with this experience, what we got, we see that one of the options which works really beautiful is to use this membrane as a shield in cases of single tooth replacement, especially in the maxilla. And in cases where you miss some vestibular bone, it can be an option just to use this membrane as a stiff wall, which will create the support for the biomaterial in case of this lateral augmentation needed. Of course, we have different options, different materials which can be used for these specific cases or indications. And what is beautiful that in the literature, we have already some of the cases visible which prove consistency and the quality of the treatment which we can get. However, honestly speaking, I was just astonished what this membrane can do, especially with one of the cases which we done more than 2 years ago. So in general, it is. I will share some slides with you from this case because it's very interesting. Because the case was referred to our office, and patient was suffering because she got in other office treatment in the upper jaw, where doctor removed impacted canines which were horizontal and placed on the palatal side, and after a while she placed implants, 3 implants, as you can see here. But from the quality of the treatment and the result what we saw on the x-ray, there was a lot of problems with inflammation. So patient was really suffering from the pain, and she felt lost in this situation. So our indication was to open the flap and clean and verify what is happening. So there was massive inflammation, as you can see. There were as well some issues with the implants positioning. So it was like a breakdown of the healing, and we actually don't know, we don't have full data what was just happening with the regeneration. Was it done, and what kind of quality of the material was used, because everything was destroyed. And additionally, there was no cover screws. So it was a lot of risk factors affecting this very fragile moment of the treatment. So our idea and the process in such cases is just to at first remove inflammation and leave it for the healing. So you see the steps with the removal of the granulation tissue. You see a lot of tissue which is inflamed, very bad quality of the material and the healing process. So as the result, we had to explant the implants, and we left the situation after healing with huge defects. Actually, there was no regeneration at all. So you can see and realize that the size of the defects is quite big. So we left patient with the soft tissue healing in this zone for a couple of months. As a standard, we leave it for from 3 to 5 months. And after this time, we took additional X-ray to verify the healing. So you realize and see the volume of the defects and the size of the tissue which is missing. So our intention in the first moment was to go with the biomaterials, of course, but with autogenous blocks or with allografts. So as the result of the second stage surgery, we used for the augmentation max graft, which is allograft coming from bodies. And from the defect size, we had to think and understand how to support the tissue and the biomaterial and isolate it from the connective tissue which could grow from the palatal side, because it's quite stiff and quite dense, and there was a risk for the misplacement of the material. So in this case, we used as an option magnesium membrane. So you see the positioning of the magnesium membrane. We filled the defect with the max graft granules. And the beauty is that this membrane is shaped, you can shape it, you can bend it, and of course you need to get used to it. So some exercise on the beginning is nice to have. But Boti's company as well offers to you special instruments which help you in shaping and cutting these membranes. So shaping, of course, is critical, and the beauty is that we have not only magnesium membranes, but we have as well magnesium pins which you can place, and they resorb as well completely. So both sides we used magnesium membranes. We fixed them with one pin on the top of the ridge, and we left everything. This is after surgery as well, after healing. So we see the volume. This vestibular volume on the left side is is left from the initial augmentations in the past from the patient. So it is not the volume which was built, but here you can see in the cross sections the volume of the material which was added on the palatal side, especially. And especially in this zone, you can realize this volume is quite nice. So on the separate pictures in a minute, you will see it in the progress. So the surgery was performed in August 2023, and after healing, the initial healing, you have to be as well aware and careful with a magnesium membrane, because during degradation it is resorbed completely, but initial degradation is with the quite massive release of the hydrogen. So as the result, it creates more swelling and sometimes a little bit more pain for the patient. So you have to inform patient about this status. So this is how it looks after 8 days, and this is how it looks after healing after 6 months. However, in the upper part, you see immediately after surgery. This is healing after 8 days. This is healing after 2-3 weeks. So you see the massive swelling on the palatal side, but after 6 months, it's getting in a better situation. So 6 months we waited for the healing. And this is the result of the CBCT, which was taken after 6 months, and this is January 2024. So we can see much better right now on the palatal, especially that the volume of the dense bone is changing. And this is the shape in the cross sections, and we can see that the volume and the width of the material is preserved. So from the quality of the regeneration as well, it looks promising. But of course, it was just CBCT, so we were really very interested to see how it looks really when we open the flap. So this is the progress of the healing. So this was a situation, initial situation when after removal of the implants and before augmentation, which was done. This is immediately after augmentation, and this is after this 6 months of healing. So beautiful width and very nice volume of the bone, which was done. So the surgery was performed with the guided surgery, and remaining 3 teeth centrals in one lateral we decided to extract because there was quite massive resorption of the teeth because this patient got additionally ortho treatment. I don't know why and what was the indication, but as the result of the very fast movement of the teeth, the roots were quite massively resorbed. So as the result, we decided to create 2 bridges supported on the implants in the front region. So this is the flap opening, and this is the place where there was a membrane and a pin. You don't see anything. This is after 6 months. So here was the pin. It is beautifully resorbed, everything. And this is the same place, and the width of the ridge is amazing. This is the position of number 23, where there was a massive, huge defect. So look at the quality of this tissue. It's dense. Here are some particles free, but here is beautiful volume built. So we decided to take a biopsy. So we took the biopsy, and we got beautiful histology. And as the result of the histology, we see that regeneration is in the upper regions of the biopsy, and we see the completely growth of the new bone. And the status of regeneration reveals a good bone implantation bed for implant insertion. So we got amazing, beautiful volume to place an implants. We placed 4 implants in total, and we created screw-retained temporal restoration, which was immediately loaded. After another 6 months, we created final restoration, which was made of zirconia, which was screw-retained with some papillas, pink papillas, because of limitations which we got with this volume. However, with the low lip dynamic and quite nice situation with the position of the lips, it was not affecting at all this aesthetics. For patient, what was very important, we created very stable result of the treatment, and patient is very, very happy out of these results. And this is the very stable volume, and the last control with x-rays is from March this year. So we have very nice observation of this volume. So this case, what was actually for us quite interesting, because it gave us foundation that we can trust this membrane. We could not only see that it disappears because we opened the flap, but as well because we could get a nice biopsy and nice result. We see the turnover of the material, including max graft and as well membrane. So as an indication, which right now Botis is quite nicely promoting, is using this membrane, Novamag membrane, as a shield, as a buccal shield. And we use it with 2 indications, with the late implantations and the immediate implantations. So this is a very interesting case from Dr. Maya Chmielewska. So Maya did this case in our office with missing premolar on the left side in the upper jaw. So this is the initial situation. And with this case, you see quite nicely on this X-ray missing vestibular volume. So of course there are few options how we can preserve this volume or build up this volume, including periostal pocket flap or just using some biomaterial. However, if we will use biomaterial without any support, stiff support, there is a high risk that this volume will change over the time. So especially when we look on the 3D view of the CBCT, we realize that this type of defect is not very difficult to restore, because we have very nice position of the bone around adjacent teeth. However, this collapse, which is right now quite big, affects, of course, aesthetic, and we would like just to have very nice shape, because in our opinion it is still aesthetic region. So what Maya did, she did very nice positioning of the implants, and she did dynamic guided surgery with Falcon system from Straumann. And she placed Straumann BLC, a selective implant, very narrow space, so position of the implants has to be very, very precisely placed. To build the vestibular shield, she used Novamag membrane. At that time, there was no shields in the shape of the shields, so we were testing and shaping the material membranes by ourselves. And what is very beautiful that, as I mentioned before, this system offers you not only membrane, but as well tools. And I like very much these fixation screws. So you see they look very massive. And they are delivered with the special handles, which are machine driver. They are called Novamag connector. So with this handle or driver, you can place or fix with such a screw membrane. You don't need a lot of them. One is enough just to fix it in the base, for instance, of the shield, that it will stay fixed. So you have to use pins. You can use connectors. You can use the regular pins, titanium pins as well, because we were testing different options and different solutions. So when you use this connector, it will this pin, after reaching the final position, it will break from the handle. So it stays the carrier inside of the adapter in this connector. So at the end, this fixation screw is fixed and holds the membrane at the base of the defect. So you see beautifully shaped membrane by itself, and Maya placed already as well the cover screw. Actually, this is healing screw, but she used the size which was used actually to the closed healing. So as a material of choice in our clinic, in majority of the cases, we use autologous or allografts. And if we mix with the xenografts, it is a mixture in the proportion of 20% of xenograft and 80% of the maxgraft granules. In this case, only maxgraft granules were used. When we are preparing or working with these membranes, you have to be careful when you are bending, because sometimes it can break. If you too much, if you bend it too many times, it can break. That's why you have to practice a little bit to learn how what is the feedback and how this membrane works with such a with handling. So it was left for closed healing, and after closed healing, we wait in general 4 months. As the recommendation from the company, the resorption time of the magnesium membrane in average is around 4 months. So we waited in this case as well 4 months, and you see here X-ray which was done after surgery. And this is CBCT showing the volume which was built, and as well the vestibular zone. Of course, there is some artifacts coming from the metal of the implant by itself. And here we see the volume. And this is the comparison before the surgery, the size of the defect with this collapse here, and how it looks with the situation immediately after the surgery. So we could compare the volume. So here on this X-ray, we can see the vestibular part, the vestibular volume, which is built around an implant. And we can see the steps actually with the healing. So what we can observe with these slides, with these pictures, that we see the volume of the defect here. We see the next step with the screw plus membrane plus max graft, closer, and this is the situation after opening. So we see a beautiful volume actually of the bone which was built up and which was created with the help of magnesium membrane. So when we look at the shape of the defect, and when we add the line to compare this green line with the position of the CEJ, we see the volume which was created and built up with max graft and this membrane, which is completely resorbed after 4 months. So we can see beautiful shape and the volume which was created, and this shape and volume is very stable. So when we look in into such a patients, we have to understand that premolars are in the aesthetic region. So we try to always, when it is possible, build the volume of the tissue, hard and soft tissue, in a way that when the patient smiles, it really can give a very pleasing result. So with the step-by-step protocol, with the step-by-step all the options, we could realize that the volume which was created gave a quite nice foundation to build the crown, which was screw retained, where the volume of the tissue, hard and soft tissue, is responsible for the long-term stability. So we need, of course, to observe such cases for the longer period of time, to be aware in which direction or how this treatment will be stable over the time. This is the last CBCT which we have of this patient. This is from April last year, and we could see the result which was achieved after the treatment, so after delivery of the crown. So when I look into the volume of the bone which was created, this is very stable, and the beautiful feature or the benefit of using magnesium membrane is that it's not only giving us a stiff wall which protects the biomaterial underneath, but as well the second part, which is related to the resorption, because during the resorption process we have magnesium ions which are released from the resorbed membrane, and these ions will support bone healing and mineralization, which gives very good foundation for very good regeneration. So from the volume which was achieved in this case, we can see once again situation before the treatment and after the treatment, including implant position. So very nice bone regeneration around implant and support for the soft tissue from the foundation, from the bone position. So from the 3D view as well, we can see the situation after delivery of the crown. So there is no remnants of the membrane. We see the nice actually density of the bone, and this is one of these benefits of the magnesium ions which are released from the membrane, which support as well this volume with more dense bone. So it is it has the tendency to build a more visible like a cortical layer. So we have very nice foundation. Another indication which we see for especially shield type of the membrane is of course with immediate implantation. And these kind of cases of course are a little bit different, because we are going to the next stage. It's not only late approach, it's with the immediacy, which is much more demanding. And here I would like to share one of the cases where it was just interesting, because this patient came to our office. She came from abroad, so she was not aware about the size of the defect and problem which she got. She got some issues with the right central in the maxilla. She realized that this tooth became a little bit of loose and it changed slightly position. So in the examination, we realized some pus coming out, and we probed the defect. So there was a deep defect around the tooth, and with the mobility of the tooth and displacement, we took few options under consideration, but as the final result, we decided to extract the tooth and regenerate the defect around an implant and around adjacent tooth. However, when we look into the type of the defect, it's the type 2B, type 2 defect, and it's the type 2B socket, where actually quite a big part of the vestibular bone is missing. And according to different type of evaluation, but as well classification, we have in such a cases soft tissue zenith in the correct position, but we are missing in type 2B or 2C from 7 to even 10 millimeters of bone. So still some remnants of the bone covers the apex of the root. So it is classified as the type 2B. This type of classification allows us to check and verify before we start the surgery what kind of materials we can use, what kind of defect is really present, and what options do we have. Of course, we have IDR technique, we have cone techniques, and in many cases, you decide what options will be the best for the patient, taking under consideration as well anatomy of the patient. If we have the volume of the, for instance, tuberosity, to go with IDR technique, or if we have a patient from abroad, or it is local patient. So we have to as well always calculate in which direction we can go with the patient. So this is just to remind a little bit what kind of defects we are talking of the post-extraction sockets. So these extraction sockets, we have actually these three types in the type 2 classification, which was just extended. So in all of these cases, you see that zenith of the soft tissue remains exactly the same. So the soft tissue is exactly the same, but there is a difference in the wall, vestibular wall defect. In case of A, B, or C, depending on the depth of this defect, we will have different, let's say, materials which we can use, and they are more or less predictable. So the most difficult is, of course, type 2C, and actually in type 2B and 2C, it's worth to consider to use a kind of stiff vestibular support for the material, that it will not be displaced. And in such a cases, it's very, very nice to think about magnesium membrane, because it seems very promising as a tool which we can use. So once again, in such a cases, we can expect the bone defect around 7 to 9 millimeters from the free gingival margin, or from the zenith of the soft tissue. So in this case, you see the initial situation with the pus coming out. So we probed the case. We didn't actually know exactly what kind of defect will be here after flap opening. I was a little bit afraid what I saw on the X-ray as well, that the defect will be going very, very deep from one side, but I was very much afraid of the position of the distal papilla. So we see the inflammation, inflamed papilla, and in such a cases, especially when the bone is missing or we have the defect, we are in the high risk of losing papilla. So this was one of our risk factors. So extraction of the tooth, we see a hopeless situation, but as well a lot of stone under the calculus, under the soft tissue. So poor hygiene of the patient. And we started with planning as well with the incision line. So we wanted to limit negative response from the bone after flap opening. So you see this type of the flap, which is like with the incision like a hockey stick, with the vertical incision in between number 13 and 12. So one vertical incision in this case. And after elevation, we can observe, after elevating slightly flap, we can observe the defect. And the defect is vertical defect. And the problem is as well that we miss this volume of the bone on the lateral. So we still see some volume of the vestibular bone over the tooth number 12. However, in the lateral view, we see that this inflammation created a process of the bone destruction as well on this proximal surface. So cleaning with the curette the surface, and after cleaning from the incisal view, we can see the volume of the bone missing, and very deep defect, and actually horizontal and vertical. So before following with the next steps, some releasing incisions, some split incision inside of the flap to mobilize it, just to avoid tension or minimize the tension. And before implant placement, we decided to prepare the shape of the magnesium membrane. So in this case, our goal was to use magnesium membrane as a shield. We created this kind of shape, and I fixed this shape in this case with 2 pins, metal pins. So these are titanium pins. You can use magnesium, but as well titanium. With titanium, it's easy handling as well, because you don't need to use any drills. You tack it and you perforate it with the titanium pins. So first of all, I created I positioned this membrane and fixed with 2 pins to create the volume, to create the wall. So after placement, initially I bended the membrane just to have this to avoid sharp edge, which could create some tension on the top of the, or a risk of perforation of the soft tissue. And you see that the flap is with already, you see some mucosa, some periostal flap, and external part, which is mucosa, which is more mobile for closure of the tissue. Before following, of course, we use as well pref gel to clean the surface of the adjacent tooth of number 12. After 2 minutes, rinsing with the saline solution, and in advance we prefer the surgical guide. So in general, in our office, we are using in 99% of the cases guided surgery. We use static and dynamic systems to have very, very precise implant positioning, which is the foundation of actually every case. It doesn't matter it is a static zone or a full arches. In every case, we need to focus on optimum positioning of the implants based on the prosto plan. So this was the planning in the co-diagnostic software, and then after installation of the membrane, we decided to place an implant. And during placement of the implant, it's critical as well just to follow the surgical report, which is delivered from the software, but as well to create special, let's say, guidance for the implant. And even if we are using the guided surgery, we have to as well think about how this implant will be placed and how to avoid displacement of the implant. Even if we are using guided surgery, there is a risk that this implant will not be placed perfectly if we do not follow specific guidelines and rules. So the first instrument which was used, it was so-called milling cutter, which creates like a flat platform in the base of the defect, which allows us as well to have a very precise position of the, let's say, chamber of the bone, which is prepared as an osteotomy, as a foundation. And after this moment, we can start and continue with the guided surgery. So we follow full protocol with including the drills from 2.2 drills, 2.8, and final preparation was prepared with the drill 3.8. 3.5, I'm sorry. So with this preparation, maximum diameter 3.5, we placed as an implant, we placed Straumann BLX, which was in the diameter 4.5. In such a cases, actually, whenever it's possible, I'm using SL Active, which gives better promotion for the adaptation or the healing of the cells. And as well, what is very important, it's rock solid, so it's an alloy of titanium and zirconium, so it is a very, very strong alloy. So 12 millimeter implants, and we see this implant on the adapter, on the carrier, positioning of the implant, and the depth of the insertion of the implant is based on the surgical report. So when it is placed according to the report, it should be in the position according to our plan. So as we can see right now, relation in between the vestibular membrane, magnesium membrane, and implant by itself. So in many cases, when we are planning aesthetic cases, when we have the natural dentition or even crowns of the patients, I extract the teeth or remove the crowns in a very gentle way, because according to my initial planning, I am trying to plan the implant in the position of the cingulum position, so where the axis to the screw channel is on the palatal side. So in such a cases, we can use natural crown of the natural tooth. So in this case, we cut the root out, and then we hollow the inside of the crown and then we can connect it with the titanium T-base or the titanium abutment, which is happening with the flow composite. So after having this done, we finish, of course, the composite to have the smooth surface. And before crown installation, I make additional sealing with the mucoderm. So I want to have additional sealing and as well the foundation for the proliferation of the fibroblasts. Before delivery of the crown, I place shortly into the implant carrier, another carrier, just to block or stop the risk that we can have some particles embedded inside of the implant. And you see here delivery of the MaxGraft granules. I love MaxGraft because it's allograft, so after the 4 to 6 months we have beautiful natural bone and no xenograft in this case. And after placement of the biomaterial, we, after rinsing, we as well deliver some emdogain on the surface of the lateral, but as well on the surface of the mucoderm. So we see the delivery of the crown. Crown was screw retained and free of contact with the lower teeth, and we see the suturing. So very stable sutures, no tension into the flap. And now, of course, the healing starts. And this is the situation with the X-ray after the surgery. So we can see the volume and comparing what is the difference in between the initial situation and right after surgery. So we can see a very, very nice volume which was created and supported with the membrane. As well, from this perspective, we can observe that the vestibular shape of the ridge is nicely preserved. And this is healing. And this was actually one of the elements which we were afraid of, what will happen with the papilla. So the height of the papilla has changed. You see the shrinkage. However, the stability of the tissue was promising. With patient, we discussed aesthetic options, in which direction we can go, and you see already some challenges. And it is actually, from the aesthetic point, it was very, very promising, because we had few options to correct the shape of the teeth, because you see some asymmetry in between left and right side. After the discussion with the patient, patient didn't actually want to have to go with ortho or any gingivoplasty or crown lengthening, especially on the right hand side. She wanted to have minimum invasive or minimal invasive type of the treatment. So what you see in between these two pictures is the beautiful work of my prostodontist from my team, Dr. Dagmara Karczewska. So she did very beautiful work with the composites and the crown. So as the result, patient was very, very happy from the shape of the tissue and the shape of the teeth and her total smile. So actually we got a very predictable result of the regeneration, because aesthetic is one story and what we were able to achieve. However, this volume which is here is the volume which is built by 3 elements, which is bone position and the soft tissue and the crown shape. And this especially shape of the hard and soft tissue, the foundation comes from the bone and the volume of the soft tissue. So as the summary of this case, I would like just only to give you information that actually when the magnesium is released during the resorption, first of all, it will promote bone remodeling, and it boosts bone mineralization, which we could really see inside of the biopsy, but as well we could see with the CBCT, but as well during the opening of the flaps. So we could verify it not only on the X-rays, but we could really verify it, especially with the histology and optical observation. Magnesium by itself as well accelerates tissue repairs and enhance blood supply. So a little bit of the commercial coming from the body side. So this, especially Novamax Shield, it is a very nice option for the socket management and bridge aesthetics, which I hope I could see, especially with these last two cases. And it gives you two options. Of course, we can have early or immediate implant placement or delay implant placement. And what kind of material we will use? You will use allograft or autologous bone or xenograft, mixture of these materials. It's up to your choice and preferences. However, in our clinic, we prefer autologous and allograft bone, and if we are mixing with xenograft, we are using the proportions 80% of the allograft and 20% of the xenograft. So Novamax Shield as a shield is maybe less invasive option for the patients. This is just something, let's say, which could act as an option if you don't want to go with the Curie techniques, or if you don't want to go with the more, let's say, invasive techniques to harvest the autologous bone. It gives volume stability for sure. No removal surgery, so no second surgery with the removal. It doesn't need additional, in some of the cases, no fixation. However, with this no fixation, I have a little bit of we have to be very careful. You have to create a really very precise superiostal pocket to hold this shield in place. It will maintain the bone structure, and it will have a really very good contour. And what is beautiful, after 4 months, you can expect that there will be no remnants of this membrane at all. With this last slide, I would like to thank you for watching this presentation, and I would like to thank my team. And without my team, a lot of things would not be possible. So this is quite often the result of many clinicians and the team dental technicians. So with this, I would like to thank you very, very much for your kind attention. Thank you very much. Once again, thank you for watching this lecture. And in the meantime, a few questions arise, so I will try to answer all of them. So first of all, are there specific anatomical sites, such as anterior maxilla versus posterior mandible, where shield is particularly effective or limited? Very good question. From our experience, this membrane works perfectly in the maxilla. In the mandible, because of dense bone and specific shape of the defect which you will have, you have to be more, let's say, selective in the cases. So in the case where you have, especially in the mandible, I would just recommend to use, let's say, with precautions, because it is more difficult to fix. So you need to pre-drill some holes in the, if you want to use the magnesium pins. And from our experience, it works much better in the maxilla. The second question, are there specific, no, I'm sorry. The second is, do you see this as a solution for general practitioners, or is it better suited for specialists due to the surgical precision involved? With the easy cases where we have the case like vestibular defects in the maxilla, when you extract the tooth and you have some minor or medium size missing vestibular plate and a good shape of the adjacent teeth, it's quite easy. You don't even have to open flap, because especially with the immediate implantation, you can just slightly elevate from the inside flap without opening with the additional incisions, and then you can just insert like a cone this membrane. So in my opinion, it's the membrane which is quite easy to use with the basic indications. The cases which I showed were more complex than basic, especially the first one, but as well with the second one, you could see that there was a lot of thinking process and decision making in the meantime. But in my opinion, with the specific indications, this membrane is, with some basic training, is quite easy for handling for general practitioners as well. I don't see any problem with it. Did you need a fixation screw in this case? So I don't know which case you mean, Bola. So what I showed already, that we could use the screws which are made of magnesium, which are resorbable and is fine. Second, the last case was with titanium pins. And sometimes we are using as well sutures. So especially when we make a split flap, sometimes in the vestibular positioning, we just use the sutures just to connect, to make like a matrix suture with the periosteum, and periosteum acts as a with the sutures on top, acts as a fixation for the membrane. So it can be used in different ways depending on your expertise and your experience. Can you compare the results of bone regeneration regarding magnesium membrane or and reinforced titanium PTFE membrane in GBR procedures? So these are two completely different membranes. So from the handling point of view, of course, PTFE membrane with titanium reinforcement, you can shape in more easy way. So especially titanium reinforcement gives you the flexibility to work and let's say build the shape according your needs. You can fix it with the pins, you can reflect it, add material, and then fix it once again. With titanium, with the magnesium membrane, you have to be careful, because too many times if you will bend it, it will break in line of bending. So it is just more fragile from this point of view. However, the huge advantage of the magnesium membrane is, first of all, it is one surgery only. You don't need to have the second surgery like with the PTFE membrane to remove it. Secondly, when it is even open, left for open healing, we observe, and we have it very beautiful documentation as well, with the proliferation of the tissue on top of the magnesium membrane. And the third benefit, which is related to the magnesium membrane, is that during the degradation process, you have the complete resolution of the material, because it resorbs to hydrogen and magnesium ions, which are very, very beneficial for healing of the tissue, for promotion of the mineralization of the tissue. So I see a lot of benefits. However, these are completely two different materials. It is one, in my opinion, it's one of the tools we add to our portfolio of the instruments which we have, and depending on the case, I work with Curie techniques, I work with PTFE membranes when it is necessary, I work with the xenograft, but as well with the allograft in majority of the cases. So everybody is using specific tools for the specific indications. Sir, do you recommend any particular bone graft before closure along the magnesium membrane? I don't know if I understand it correctly, but first of all, as one of the last slides, we can use with the immediate implantation, in most of the cases I will use allograft, or the combination of allograft with autogenous bone. For the regular bone regeneration, I make a mixture of 80% of allograft or autogenous bone and 20% of the xenograft. on top of the membrane, of magnesium membrane, we were using as an additional protection, because we thought it's needed, some collagen membranes, but after a few cases we realized that it is not needed, and sometimes it can be additional, let's say, barrier which is not needed. So we don't cover magnesium membrane with any other material. Great lecture, thank you, Anne-Marie. How predictable is the resorption rate of the shield across different patients or clinical situation? So in every case, the resorption more or less after 4 months is done. The only issue is that within the first 2-3 weeks after placement of the magnesium membrane, you have to inform patient that there will be a little bit more swelling because of the hydrogen release. And as well, it can somehow be associated with some pain. So when patient knows it, it's a completely different story. But if you will not give this information to the patient, it can affect that patient will feel unsafe, or this additional pain can cause some troubles. But in general, in all of the cases, the healing went really good. Some of the cases, especially when we used a huge or big membranes, on the beginning we were testing for different indications. We had some soft tissue opening, but so we have beautiful documentation how the soft tissue heals in the after even if it was left open. For instance, in case of the extraction of the molars, we did some cases where we were just following and checking what is the actually response from the body and how it is healed. So we can recommend it. How long approximately does the area stay swollen in comparison to a non-magnesium plus shield? So as I mentioned, the difference is more or less the first 2 weeks, when this massive hydrogen release is on the beginning. So in most of the cases, this first 2 weeks, patients should be informed that it will be a little bit more swelling, a little bit of reddish tissue, but it disappears with time. So this is the last question, and I see from Sylwia, świetna prezentacja, pozdrawiam z Karoliny, pozdrawiam Sylwia, so it was in Polish, I'm sorry. Complications associated with this membrane and exposure engagement and management. So I already partially replied to this question from Dr. Rania. So in cases where we have the exposure of the membrane, we don't remove it, we leave it. And because of limited time, I couldn't show complications and the management of the complications. But in every case, we were just doing using magnesium. We were documenting with photographs, so we know exactly from our experience in which situations we should use it, and which maybe other techniques or other materials. So I don't want to give some general advice when to use, when not to use, because it needs some additional explanation and showing the differences. But as a general conclusion, I would say, especially when we are using it with the shield, it works perfectly in the maxilla, where we have a little bit of different bone situation compared to very dense bone, which is in the mandible. So I hope all of this was worth watching, and I hope some of the tips and tricks which I shared with you will be useful. But don't trust my opinion. Just the best is to gain your experience with using these materials. But first of all, when you want to start, please watch some webinars, but as well some materials which are on the Botis website, where you can see as well some videos with handling of the membrane, how to shape it, how to cut it, how to trim it, and how to fix it as well. So with this, I think we don't have any more questions. So thank you very much.
Thank you, Dr. Chmielewski, for introducing the shield concept, sharing indications, procedural steps, and clinical outcomes. We'll return shortly with our final session. For our concluding session, end-to-end digital workflow in full arches, Dr. Estanislao Planas will map out a seamless digital pathway, from planning and guided surgery through to immediate prosthesis delivery. You'll see how to integrate tools and protocols to enhance precision, efficiency, and patient satisfaction in full arch cases. This is your chance to see a complete optimized workflow in action and take away actionable steps for your own practice.
First of all, I have to give thanks to DD Study Club to give me the opportunity to be here with all the audience to speak about all the digital workflow that we use to build up and to perform the prosthesis for the full arches that we usually do in our dental office. My name is Stanislaw Planas. I'm a dentist. I'm an oral surgeon. And apart from that, I'm a prosthodontist. So basically, what I do with my patients is that we perform the surgery. And after that, we have to build the prosthesis that has to go on that full arch rehabilitation. Okay. And that brings us to the fact that what was the problem that we were having before the digital new world started. Well, the thing is I was talking about that in our dental office, we are performing usually like maybe 2 or 3 cases of full arch rehabilitations per week. Okay. And that meant that we had to spend like quite a lot of time performing different clients and having a lot of travels from the dental office to the lab technician. And apart from that, we have to take in consideration that our dental office, or where I live in, it's the beautiful island called Mallorca, which is beautiful. We have like the beach, we have seaside, we have all of those things. But sometimes it's a little bit difficult to find good lab technicians that we can work with, okay? So that's why we try to think about what would be the best option to try to cover the requirements that we should need to give our patients the best work that we could deliver, okay? And in between those requirements, the things that we had, we thought that were the most important ones, or the things that we thought that we should try to have. First of all, it's that we should have a passive adjustment, that there would be no forces that could damage our implants for long term. Apart from that, that the patients could have a good occlusion that they could bite and they could chew in a proper way. Obviously, and it's one of the most important things why the patients come to us, because they want to improve their aesthetics. And apart from that, I mean, they want to speak and they want to communicate, okay? They want to feel themselves better and more self-confident, okay? And apart from that, when we choose the type of prostheses that we're looking for, we also want prostheses that are resistant, okay? And this is something that I want to try to transmit, or something that was with the old way, or the old-fashioned way of building up our prostheses. We were having some trouble or some problems sometimes with some of those teeth that could just break while the patients were using. And obviously, the prostheses, they should be the more hygienic as possible in order to maintain those implants and in order to have those implants for many, many, many years doing their work inside the patient's mouth. Okay? So once we had these requirements clear, what we thought about is which method do we have for building up to have that prosthesis. Well, in the old days, the method that we used to work with was the analog flow, okay, which basically was screwing up or transfer abutments, splinting all of them, okay, and then once we had it done splinted, take an impression, and from that impression, take a plaster model, which we could also check out with another splint once we took it to the lab to check out that everything was fitting properly, okay? But the problem was that with this method, with the analog flow method, we found out, well, first of all, from the advantages, it was that it was something that we had been practicing for many, many, many years. So we have a lot of experience, and that it was economic in the way that we didn't need to invest in specific devices or whatsoever to try to report the position and the bone and the soft tissues of our implants. Okay, but as I was talking about, we also have a lot of disadvantages. Okay, and those disadvantages were that they took a long more time to work with, because we have to have our patient coming to the dental office and screwing all the abutments, taking the impressions, then doing different try-ins, which meant that we increased the number of appointments that the patient should come to our dental office. It was uncomfortable for the patient because we have to make we have to take the impressions, and those impressions were quite uncomfortable for them. And also, it was, as it was something analog, it could mean that we could have a series of cumulative errors, which means that if we had some error in the beginning, that error would keep on with different finds that we were doing until the end, when we would have a prosthesis that wouldn't fit in a proper way. Okay. And apart from that, the thing about the logistics that it meant, I mean, maybe 10 or 15 years ago, it was something quite difficult to think about, to have a dental technician that was far away from the city where we were working. And especially in my case, as we live in an island, which that means that everything, all the trials that you have to do, you have to send them by plane, and that means that the treatments could delay a lot in time. Okay, so that's why it was one of the options, or one of the reasons why we decided to change from this analog flow to a digital flow. When we recorded all the different parts of the position of the implants and how it fitted inside the patient's mouth and everything. Okay. And this record taking began with the intraoral scanning. Okay, once the intraoral scanning has been democratized, that everyone can, or almost anyone can afford an intraoral scanning. I think it was a jump in quality sense. Okay, which meant that we could start doing things that were for the patient quite a lot more comfortable. Okay. Part of that, after the intraoral scanning, we also started having the photogrammetry, which meant that we could get the exact position of the implants inside the patient's mouth, the lateral passive and the passive adjustment of prosthesis. Apart from that, we also have the facial scanners, okay, which those facial scanners will help us a lot in order to design the prosthesis and to see how the prosthesis will fit even if we haven't started building out anything. I mean, once we've started designing, that facial scanner will help us to have that prosthesis built out. Okay. And before those facial scanners, we also had the possibility of taking pictures and sending them to the dental technician, which he could also work with. Okay. So with these different tools that we have in order to record the different parameters of a patient, let's go and see one by one what they will do. Okay. For me, it was discovery. I mean, the intraoral scanning. For me, it's a before and after in my dental practice. And I think that also in the way the patients, how do they feel, okay. As I suppose that most of the people know nowadays, when we perform the intraoral scanning, the first thing that we have to do is we have to take the scan of what it would be the soft tissues to see exactly how those soft tissues are in order for the lab technician to start designing and to have them as the best way for the hygiene and for the different things. Okay. Once we have recorded those soft tissues, what we used to do is that we would use the scan bodies, and with those scan bodies, we could record the position of the implants. I mean, I think I'm not talking about nothing, which is almost everyone nowadays can know about it. Okay? And with the professional processes that we had, we could have the relationship, okay, if we scan the temporary prosthesis, the upper temporary prosthesis and the lower temporary prosthesis, we could upload them, and there we could have what would be the position of the maxilla with the lower jaw and the upper jaw. Okay, and starting with this, our lab technician could start with it. Okay. The problem with the conventional scan bodies were that the advantages, about the conventional scan body that we used in the beginning was that for the patient, it was more comfortable than taking the old-fashioned impressions with silicone, and that they were faster than analog, and they could even, once we scan it, we can send it directly to our lab technician. That, for example, in my case, I'm working with a lab technician that it's not in the mainland of Spain, but in another part in the Canary Islands, which is a group of islands which are just at the south of Spain, but they're quite far away. Okay, and we just scan it, we send it, and our lab technician can have it just at the border. Okay, those are the advantages. But apart from those advantages, we've also found some disadvantages. Okay, and the disadvantages that we could find was that, first of all, what I was talking about, that we had to buy an intraoral scanner, which nowadays, even though they have been lowering down the price, and nowadays we can find very good intraoral scanners with quite a competitive cost. But I mean, it's more the cost that it's supposed, it's bigger than if we have to take a normal impression. And this other part, which is something that we really find that we had some trouble with, was then when we were trying to register atrophic maxillars, let's say, especially for the lower jaws, where we have a small amount of characterized tissue. That would take us quite a lot of time to scan, and sometimes it was quite difficult to get a proper scanning. Okay, we can have here that the average deviation that we can have, it's 75 millimeters. Okay, with the study of Papasiakos, which means that here we're having some deviation problems, some unprecise work that we should have. Okay, so that was one of the reasons why we said, okay, now we have this tool that it's working quite well. Why don't we try something that maybe can give us a little bit more, that it's a little bit more precise, okay? And that's why we started using the reverse scan bodies, okay? The reverse scan bodies, nowadays we have different brands, as we can have, for example, the standard Rebex or the Neoden Rebex or the Evo, which are some scan bodies which work in the following way. Okay, what we do is that what we have to think about is that when we're rehabilitating the full arches, we start, okay, with an identical jaw where we place our implants, and we have those cylinders, okay, and those cylinders are screwed directly to our implants, okay. Once we have those cylinders screwed, what we do is that we capture those cylinders into our temporary prosthesis, okay? And that temporary prosthesis, we send it to a lab technician. Okay, you can see over there, our lab technician will prepare the prosthesis, okay? And he will send it back to us, so the patient can stay with it while we're waiting for the healing period of those implants, okay? Once that time has passed, what we do is that we unscrew that prosthesis and we screw those reverse scan bodies. And what we do then is that we scan that prosthesis with the reverse scan body, and that prosthesis with the reverse scan body, they can match it with the other scanning that we have performed with the soft tissues. So they can, the lab technician, he can place the exact position of those implants. Okay, and for me, the truth is that it has been something which has been a discovery. I mean, it's something which has helped us a lot, especially when we had those limited keratinized gingiva, as I was talking about, especially in the lower jaw. And it saved us quite a lot of time while we are working than the conventional scan bodies, okay? Because we don't have the scanner that it's getting lost all of the time, okay? The disadvantages that we have is that there's still not a lot of scientific evidence, as we have been working for only a couple of years with these reverse scan bodies. And that even though we don't have 75 meters of average deviation as we had with normal scan bodies, we still have 40 meters of average deviation, okay? And that's why here it's when the photogrammetry comes in, okay? And well, we can find that the photogrammetry, I must explain what we have. It's that we have this sort of flags that we have to screw on those implants. We screw them, okay? and we take like a picture that will tell us exactly in a 3D in a 3D space. Then it will tell us exactly where and how are positioned those implants. Okay, and the best part of it is that it's very, very, very precise, much more than the traditional oral scanning. But as we have some advantages, we also have some disadvantages. And I think that the main or the most, the worst disadvantage that we have nowadays, it's that these devices, they're quite expensive. Okay, and that's why not everyone can afford one of those machines in his dental office. Okay, and apart from that, that this type of technology, it doesn't record the soft tissue that we have, or it doesn't record either the emergency profile. So what we'll have to do is that we have to record the position of those implants, and then we also have to make an intraoral scanning to record or to have how the soft tissues are, and match both of them to have what the position with the soft tissues are. Okay, so more or less we're doing the same work as with the reverse scan bodies. Okay. And apart from that, it also requires a specific training. Okay, it's a little bit more difficult than the intraoral scanning. And that would mean that we should also have like a learning curve before we feel quite comfortable working with them. Okay. Well, I've been speaking about the way that we can have the record, the intraoral scanning, the conventional, the scan body, the photogrammetry. This is another part that we decided to add in dental office and in the day-to-day in order to have a good communication and a better design of the work that we do or what we try to give to our patients. Okay, the facial scan, basically what it does, it works like an intraoral scanner, but what we do is that we capture all of the facial aspects of the patient. Okay, those facial aspects, then we would ask the patient, we would do two different facial scans. One with the mouth opener, sort of a spandex, okay, and the other one with the patient's smile, okay, and in that way we could have once we have that scanner performed, we get the facial scan, we have our intraoral scanning, and we also have our CBCP, light from the iPhone. Okay, and with that, what we can get in the end, okay, it's that we can have our patient with the old prosthesis, and where we can see different aspects. Okay, you can see here the old prosthesis of the patient, and now what we're talking about that we want to maybe try to move it a bit upward, a bit more to the front. Here we get inside. Okay, here we have the soft features. We can see the old prostheses, how they were, and how we want our prostheses to get in. And we can check also things as a smile line, the size of the teeth, what's the orientation of our crucial plane, and how the relationship between the bone, the implant, and the prosthesis is. Okay, so we're like taking the whole head of the patient, we're taking it to our lab technician, so the lab technician can work with it. Okay, and therefore, I mean, all the advantages that we can have with this facial scan is that it's something which is non-invasive. I mean, with the only things that we take good pictures, so we can build up a net. And I mean, there's no type of radiation. It has a high precision. We can see everything, so we can draw the different lines, so they can start designing the laboratory. And that means that we will deliver prostheses that will fit perfectly inside the mouth of our patient. What I'm talking about, it's like sending the head of our patient, cutting it and sending it to the lab so he can start working with it. Okay. So it's a great tool in order to communicate with our lab technician and even to communicate with our patients, because in this way, what we can do is that we can show this, what I was just showing with the video. We can show it also to the patient even before they can start printing or milling the temporary the prostheses that we are going to give afterwards to the patient. Okay, and this is something which helps us to have digital planning, which nowadays it's what we're looking for. Okay, as a disadvantage, what I could say is that it's more laborious, especially if we compare it with pictures, with the normal photographies that we usually used to take, and it requires an investment. It's not the same thing as it's not the same investment as with photogrammetry, but we have to invest some money in order to have this scanner. Okay, but I think it's worth it. Okay. So what I was telling you before, we had this face scan, and even with this face scan, what we also do is we take a digital picture, digital photography. Okay, here we have our patient, and we do it. We take here, he's wearing his temporary prosthesis, and we take a picture also with mouth openers. So in the lab, what they can do also is that they can draw the different lines, as you can see, the bicuspidor, the midline, the smile line. You can see everything, and they can start designing also. Which it's another way of working, or it's something that maybe it's those people that they don't have this facial scanner. It's something that is quite useful. What we can do is that we can plan, we can see all the different aesthetic parameters, and the only problem is that we can only see how it fits in the patient's face in a 2D way. But it's a good tool in order to have, or having a communication with the lab. They can send it. Sometimes they can even text me with a WhatsApp or whatever and tell me, well, what do you think about it? And just take a look and say, okay, you can go for it, or we have to try to change some things that maybe we don't like or we don't think about. Okay. So once we've recorded all those parameters, we have to say it's the how do we build how can we be sure that what we've been recording, they are correct, and that we can see that everything's all right, or it's okay. And for that, what we're doing is, in one side, we have this facility bars that I will speak now about one, and then a public slide. The facility bar, what we do is that we have aluminum free, that it's nil, okay, and that we can screw it. Here is aluminum free, that it can also be of PET, or it can also be made out of titanium. Usually in our office, what we're working with, it's with PET or with aluminum, even though with PET, the problem that we were having sometimes is that with the X-rays, we couldn't see properly if it fitted well on our implants or not. Okay. And what it works for is that we can check the facility of our digital impression and perform what is a single screw test. Okay. In which we basically, try to fit in this aluminum free, and we try to screw one of those implants and check that all of the implants are completely fitted around that structure that we have. Okay. In that way, we can see that everything's good and that we won't have any sort of forces that can damage our implants. If we see that there's any sort of discrepancy, what we do is that we segment that prosthesis, we cut it into small pieces, and then we take this to our mouth, we splint it, and then we rescan it. Okay. And if we want to check it out, they can build a second facility bar, and we can try it again just to make sure that all the verification that we have afterwards will be completely passed. Okay. Well, and once we've done that part of the anatomical plan, the second part that we have to do, and which is something which is really important and that it helped us a lot, is the anatomical triad, which basically it's a provisional prosthesis, which is usually made in PMMA, or it can be built up in different types of materials. Okay. And this provisional prosthesis, we can take it to the mouth of the patient, and we can tell the patient, okay, you can take it home. So, or your husband, or your wife, or your mother, or your son, whoever lives with you, they can take a look and tell you if you look good, if you can speak properly, if you can bite properly, if you don't bite yourself, if you don't bite the tongues or whatsoever. Okay. And well, basically what it helps us, it's that when the patient, if he wears it like for 2 or 3 days, he can tell us if everything's going fine. And if everything's going fine, we can ask the lab technician to go ahead and start building the definite prosthesis. Okay. Two other things that we have to check also is that we have enough space for prosthesis, and also that the design of the patient, if they can clean it, or she can clean it properly, and that there's no problem with that. Okay. And once we have all of these reports and everything, we end up having our prosthesis. Okay. And this prosthesis, depending on the amount of prosthetic space that we have, we know that we can have a fixed prosthesis type 1, where we don't have any sort of bone or artificial gum. We can have a fixed prosthesis type 2 with some artificial gum and artificial bone, and fixed prosthesis type 3, which are the ones that we usually perform more, as most of the patients that we have in our dental office, they come with very atrophic jaws. Okay. So once we've decided what type of prosthesis are we going to need, we will have a meal detailing framework that is done by GATEC. Okay. You can see this wonderful work that we have. It also brings with some report that we can give also to the patient, and with some warranties and whatsoever, so the patient can know that what we are delivering is a high quality product. Okay. And over this framework, what we can have, it's different superstructures. Okay. In those superstructures, we can have the zirconia, for example, which is top class, the best material that we can have in terms of durability and in terms of aesthetics. The only problem is that it's a little bit expensive, and that it's also quite rigid. We can also have the ceramic reinforced composite. Okay, but we've been doing some works. It's even more aesthetic. The only problem is that it's also more porous, so it can get with the pass of time, it can get more eroded and get stained. Okay, which it's one of the reasons because we're not working quite a lot with the composite. And the last, which is the one that usually we work more, which is for us the perfect combination between something which the price it's not too high, it's more elastic, and the patients feel it quite comfortable, as it's also lighter than the zirconia. It's the HIPC, okay, which is a high impact polymer composite that it's also reinforced and that it's giving us quite good results. Okay, so this would be basically the way that we are working and the way that we are delivering prostheses for the full arches. Okay. And I would like to end up with a clinical case of Juan Jose. Juan Jose came to us because he had a terrible state of his mouth. You can see he had multiple tooth decays. He had also periodontal disease. And we decided that we must extract all of his teeth, place 4 implants on every arch, and place his temporary prosthesis. Okay, so this is Juan Jose. Once we extracted, we placed the implants. We had those implants, those Helix GM from Neodent. We had those new arch placed, 4 at the top, 4 at the bottom, and you can see what different beautiful change that we had just with the first part of treatment. Once we had done that, what I was speaking about, we started with different parts. We started scanning his temporary prosthesis, because as you can see here, he was there were, with the healing of the gums and everything, all the tissues get retracted. We also scanned the upper part, okay, and we have here his prosthesis with the upper prosthesis scan, and then the relationship between the upper and the lower, so we can see where the upper and the lower jaw are. Okay. Once we've done this, we will record the soft tissue, okay, and the emergency profile. So we start having all the prostheses that it disappears. Okay, we do the same for the upper jaw. Okay, we start scanning. We can see how the prostheses start disappearing, and in that way we can have the relationship between the upper and the lower jaw. Okay, we send that to a lab technician, and on the other way, what we do is that we start scanning with the reverse scan bodies, the upper, the lower, okay, and we send them also so they can match the temporary prostheses with the reverse scan bodies, and also the facial scanning, as I told you, okay, with just smiling and with the mouth opener. That bring us two different models. One with without the mouth retracted, and one with the mouth retracted. Okay, and with all of this information, okay, what we will do is that we send it to our dental technician, which is Fergifon in the Canary Islands, and there Fergifon starts performing his magic. Here you can see the model, how it is, the temporary prosthesis, how the lower jaw is, how the upper jaw is also, the position of the implants, everything with now the reverse scan bodies. You can see that the upper jaw especially, that we can have quite a lot of bone, okay? And once we have this, and once we have this with the scanning, we can see the soft tissues, we can see everything, okay? And how we can start working. Now we'll see that he takes out the bone. He checks that the position of those implants, more or less, it's the same as what we've been recording. And he will start with the soft tissues designing. Okay, that's the lower part, the upper part. Trying to check that everything's more or less related, and with the gums. And once we have this, we take it back again to the face of the patient, see that it comes, the coincidence with everything. We can see like as if we have X-ray vision, we'll see how everything's related. See also the different movements as the laterality and percussive movements, okay? So that we have different, the anterior and the lateral guide. And, that would be it, okay? Once it's done that, he sends the clinical verifications, as I told you. First of all, the aluminum free, just to check and see that everything fits all right. Okay, the facility test. And then what we do is that we take the anatomical test, okay, where we try in the prosthesis, what these prosthesis will be, okay? Once we see that everything's fine, okay, he designs what it would be the bar, the superstructure, and he sends us back these beautiful prostheses, which are hygienic, with the titanium bar, everything fitting completely in the proper manner, completely polished, so we don't have any trouble with the plate getting stuck into it, okay? With as I said, with the Quebec blender structure and IPC superstructure cemented towards this blender structure. And here we can see those structures inside his mouth, and palpation, which is Juan Jose, which he only had to come to perform his prosthesis, to build them his prosthesis just in 3 appointments. We passed from this old man to a mature man, and especially with one of the things that Juan Jose told us, that he didn't want to come a lot of time, a lot of visits, to a lot of appointments to a dental office, okay? Because he didn't want to spend so much time, okay, in the dental office. So to end up, the conclusions that we have, it's that first of all, with this digital workflow, what we could get in was that we could reduce the number of errors, and especially the number of appointments. We can also have a better way of communicating, and therefore getting better work, as we can speak in a way that we can understand each other with a lab technician. It's more comfortable and it's more faster for the patient. It allows us to work in a different place. I mean, we can have a lab technician that it's like 2,000 kilometers away from our island, and we can work with him, and we can speak, and we can do everything as if he was just working on the street nearby our dental office. And well, here we have both. Okay. to sailing, and it's very tough. I'm really thankful having done all of this treatment and in such a small amount of time, and we giving him back the years that he had lost, especially to do what he likes best, which is saving with his wife and his grandsons. This is the end. I hope it has been helpful, that maybe part of what we do here in a small island of Mallorca can inspire you and can help you. I leave you here my email, and you can also text me in my Instagram, and I would be very, I would like to help you in all the things that you might need about digital workflows or so on. Okay. Thank you very much. Thank you once again to the study group for taking me in consideration to come here, and also to Neoland, which is the firm in which we trust in our implants, and that has also given me the opportunity to be here talking about our full arch cases. Thank you very much. Well, hello once again, everybody. Now we have some questions time to me to answer. If it's okay for you, I'll start with a question that says, "What are my preferences for final prosthetic materials in full arch cases?" Well, as I've been talking about it during my presentation, for us, we have the three different materials. One would be the zirconia. Well, always, or trying to always have a titanium frame or structure that it's milled, and over this, usually we place or zirconia superstructure, or HIPC, which is a high polymer, high impact polymer, okay, which is really resistant. In my case, or for us, the gold standard would be the second one, the HIPC, because of the flexibility, and it has just the midpoint between aesthetic, and also it's not an expensive material. It's a lightweight material, and for us it's the most common material used in a dental office. Okay. Then we have another question which asks if photogrammetry is used only for multi-unit abutments. They are asking. Usually in full arch cases, what we always recommend is to use some sort of multi-unit abutment. It can be the Straumann screw retained abutments or the multi-unit classic abutments. But usually what we recommend is to use a multi-unit abutment in every full arch case for different purposes, as you might all know, as for example, having the gap completely sealed so we don't have bone loss. Usually we place the multi-unit abutment, and we don't want to screw it in any time. So we leave it over there, so we don't have any bone loss along the path of the years. If we are working if we're taking an impression, I know that there are certain devices that allow us to place flags that are direct onto the implant. But if you want my advice, if you're working in full arch cases, I would always go for a multi-unit abutment. I wouldn't go to a connection that goes directly to an implant. Okay, I think this is something that it was talked a long time ago, and sometime like 20, 15 years ago, some of us didn't go for it. And nowadays, I think that everyone that's doing proper work and working in full arches, they must all use some sort of intermediate abutment for full arch cases, or even for not only full arch cases, but maybe for placing 2 or 3 implants that have to be together. We should go for this intermediate abutment in order to obtain all the benefits that we can get with them. Okay. Then we have another question that says that how do I handle asymmetrical bone availability when planning implant positioning digitally in full arch cases? Well, what we have to think about when we are trying to place our implants, the most important thing, or what we should take into advice, is that we must have an anterior-posterior distribution of our implants. That means that we should have something where we can have support in the anterior part, and also in the posterior part. Sometimes we go for pterygoid implants, sometimes we go for zygomatic implants, or sometimes we go for tilted implants. And we can have, in some cases, that maybe we go for a tilted implant in one side and anterior support with one implant, and on the other side we might have an anterior implant, and if we don't have enough bone, we might go for zygomatic implant. The most important thing is that all the forces are evenly distributed, and for that, what we have to go for, or what we should look for, it's a good anchorage of our implants. And it doesn't matter if we go for tilted, zygomatic, pterygoid, as long as we have a uniform support of our full arch prosthesis. Okay. We have another question that says, how do you manage soft tissue support and aesthetic transitions digitally, especially in high smile line cases? Well, as I've been speaking about with the facial scanner, when we're doing the first part, when we are planning the implants that we are going to place, what we can do is, when we are asking for the patient to give us his biggest smile, we can see where is this smile line. And starting from here, we have to think about that we must have at least 1, or if it's better, 2 millimeters above that, our transition zone. Okay, so that is something that digitally we can handle it with a facial scanner, or even if we take some pictures of the patient, we can also take into advice and see what we have to do. Okay, that's one part for the planning part. Once we are starting to build up the final prosthesis, usually what we do is, as we've done the temporary, the provisional prosthesis, we've made it in an analog way, as we took an impression and we made some pressure over our soft tissues. What we do is that we scan with the reverse scan bodies, and we also scan that prosthesis. In that way, what we're getting, it's the emergency profile of our prosthesis, and our lab technician can take that as